Hi everyone, good afternoon and welcome to this session which is going to be a revision session for the FMG. So please let me know if I am audible and visible and we can start the session. Am I audible and visible? Okay, so let us start with this. We are going to discuss a set of like MCQs, and as we discuss the MCQs, I will also be discussing the relevant theory and whatever is important along with it. So shall we begin with the questions? Please let me know if I am audible and visible to all of you. Visible now. There seemed to be some problem with this with the connection, and that's why I had to log out. I hope you can hear me now. Please let me know with a thumbs up if I'm audible and visible, and then we can start. Am I audible and visible to everyone now? Okay, so let us start with the questions. We will be going through some important questions, and as we go, we will also be discussing what is the important theory related to that particular topic. So, शुरू करते हैं. So look at this question. Most of them are often repeated questions. Many of them are PYQs from FMG. Some of them are PYQs from the other exams. But it's not just about the answer actually, because most of you will know the answers. It's about knowing the relevant associated things so that it becomes a discussion of the PYT rather than just the PYQ. So see, a 6-year-old boy presents with complaint of itching in both the eyes. So see, a boy between say 5 to 15 years of age, the main complaint is itching. On examination, the conjunctiva is muddy and we have cobblestone papillae, and this is the appearance. What is this appearance? This is a picture of the everted upper lid, right? And in the everted upper lid, we are able to see these kind of flat topped elevations. So these kind of flat topped elevations, what are they called? They are called as our papillae, and this appearance of the conjunctiva, it is called as the cobblestone appearance. So what is the answer? Correct. The answer is vernal keratoconjunctivitis. Now, vernal keratoconjunctivitis or VKC, this is a type of recurrent allergic conjunctivitis which is seen in boys between 5 to 15 years of age just before the onset of the peak summer months, and hence the name spring catarrh. Right? So sometimes you may not have VKC in the options like it was there in last year's paper. In the options you had spring catarrh. So please remember the other name for VKC is spring catarrh, and it is what type of hypersensitivity? It is a type 1 hypersensitivity. I'll just go through the important points to remember in these topics. So it's a type 1 hypersensitivity, and therefore it is mediated by IgE, and the type of cells that are involved in this are the mast cells, right? And what are the important features? One is, as we just saw, the cobblestone papillae which are there on the upper tarsal conjunctiva or the upper palpebral conjunctiva, and the other feature is that close to the upper limbus we have small whitish lesions which are called as our HT spots or the Horner-Trantas spots. So cobblestone appearance or cobblestone papillae on the upper tarsal conjunctiva, HT spots on the upper limbus, and associated with this we can have an ulcer which is also called as the shield ulcer. So all these can be asked in the exam. Right, so this is about vernal keratoconjunctivitis. Shall we move on to the next question? Have a look at this question. What is the condition associated with the cataract in the picture? Again, another very commonly asked image-based question. So when we look at the image, what do we see? We see this kind of a shiny opacity, and if I outline this opacity, see what it looks like. What does it look like? What is the name of this cataract? Correct. This is typically what we call as the Christmas tree cataract. This is what we typically call as Christmas tree cataract. And where do we get to see Christmas tree cataract? Correct. We get to see Christmas tree cataract in myotonic dystrophy. So this is another important IBQ as well as one-liner. Now to quickly revise, what is the name of the cataract that we see in blunt trauma? In blunt trauma, the cataract that we see is called as the rosette cataract. In galactosemia, what is the type of cataract? In galactosemia, the name of the cataract is oil droplet cataract. In galactosemia, we have oil droplet cataract. Correct. And what is the typical morphology of steroid-induced cataract? Remember, systemic steroids are the most common drug associated with cataract. And steroid-induced cataract is what type of cataract? Typically, it is a type of posterior subcapsular cataract. So, steroid-induced cataract is posterior subcapsular cataract, and systemic steroids are the most common drug which is associated with cataract. Right? Now quickly a couple more. Will you tell me where do we get to see sunflower cataract? Two more important MCQs. Where do we get to see sunflower cataract? Sunflower cataract, where do we get to see? And where do we get to see snowflake cataract? Snowflake cataract. Correct. Sunflower cataract is seen in Wilson's disease, which is due to the deposition of copper. And snowflake cataract is typically described where? It is typically described in diabetes mellitus. Good. It is seen in diabetes mellitus. It is typically described in diabetes mellitus. Correct. Okay, so another whole set of one-liners associated with this one question. Right? Let's go to the next question. I have just kept the questions in a random order. I did not want to discuss all the questions in a particular topic together because see, in the exam, we have to keep this idea of switching from one topic to another, maybe from one subject to another. So at least that randomness should be there. Otherwise, see, when we try to recall all the questions from one topic, ना तो वो जल्दी याद आता है. But जब हम shift करते हैं तो थोड़ा वो brain में muddle होता है. So let's try to practice it that way only. So chalo, what is true about the condition in this clinical photograph? So what is the condition in this clinical photograph? So dekho, we can see this kind of a nodule, reddish nodule close to the limbus. This nodule is called as your Flickten. So basically this is a picture of Flicktenular conjunctivitis. So we have to say what is true about this condition. So Flicktenular conjunctivitis is not known as spring catarrh. Why? Spring catarrh is the other name for vernal keratoconjunctivitis, right? And Flicktenular conjunctivitis is not a type 3 hypersensitivity, it is a type 4 hypersensitivity reaction. That is why in India the most common association is with tuberculosis, and worldwide the strongest association is with Staph aureus. The most common association is with Staph aureus. So it's not a type 3 hypersensitivity, it is a type 4 hypersensitivity. And antihistaminics are not the treatment. The treatment is actually steroids under the cover of ATT in India. Steroids under the cover of anti-tubercular therapy in India, because as I said, the most common association in India is tuberculosis. So all this is wrong. It's not spring catarrh, it's not type 3 hypersensitivity, antihistaminics are not the treatment. So the answer is this fascicular ulcer is seen. So basically Flickten, this nodule that is close to the limbus is called as the Flickten, and if it is not properly treated, it can encroach upon the surrounding cornea and there it can end up forming an ulcer, and this ulcer is called as our fascicular ulcer. Okay? So this is what the answer to this question C, that is fascicular ulcer, is C. Chale next question pe. Chalo. Which is the nerve affected here? So we have to look at this image. See, look at this. This is the right eye. This is the left eye. तो हमें क्या दिख रहा है यहाँ पे? What can we see in this picture? Now see, This picture is not a picture of right eye ptosis. It is a picture of left eye lag ophthalmos. This picture is showing us left eye lag ophthalmos. देखो ये right eye ptosis नहीं है. ये right eye ptosis क्यों नहीं है? Because see, this is actually a picture of both eyes closed, where the left eye is actually not closing properly. Why the left eye is not closing properly? Because there is a paralysis of which muscle? Of the orbicularis oculi. Because orbicularis oculi is the muscle responsible for lid closure, and it is supplied by which nerve? It is supplied by the seventh nerve, that is the facial nerve. So do not make a mistake of thinking that this is right eye ptosis. ये right eye ptosis नहीं है. It's not right eye ptosis. It's actually left eye lag ophthalmos. And how do we decide that it is left eye lag ophthalmos? Because this actually both eye closed, where the left eye is not closing properly. I know that because I cannot see the iris in the left eye. See, if it is an open eye, I will be able to see the iris. When you close the eye, what happens is that the eyeball rotates upwards. This is called as Bell's phenomenon. So when you close the eyes, the eyeball rotates upwards. That's called as Bell's phenomenon. That's why you're not able to see the iris here. तो उसका मतलब ये है कि this is not actually an open eye. It's a closed eye which is not closed properly. So this is not a picture of right eye ptosis. It's a picture of left eye lag ophthalmos, meaning both the eyes are closed but left eye is not closing properly. So which is the muscle for lid closure? It is orbicularis, and that's what is affected here. So therefore the nerve affected is the seventh nerve or the facial nerve, which supplies the orbicularis oculi. समझ आया? Let's go to the next question. A contact lens user fails to remove the contact lens while sleeping and develops a painful red eye after a couple of days. And this is the clinical picture that is given to us. So look at the clinical picture. So यहाँ पे what are the keywords in the question? The keywords is that it's a contact lens misuser. And you look at the shape of the ulcer. This is typically a ring ulcer. So see, the ulcer is shaped like a ring. So contact lens misuser who develops a ring ulcer, the answer is 𝐒𝐿 keratitis. 𝐒𝐿 keratitis. Now please remember, just because it is a contact lens misuser who's developing an ulcer, the answer is not 𝐒𝐿. क्यों? Because the most common organism which causes an ulcer in a contact lens misuser is actually Pseudomonas. It is actually Pseudomonas. Even in a contact lens misuser, the most common organism which causes a corneal ulcer or an infective keratitis is Pseudomonas. So just because it is a contact lens misuser, the answer does not automatically become 𝐒𝐿. Why we are calling this as 𝐒𝐿 is because there is a ring ulcer, and ring ulcer is one of the things that tells us, that is more specific to the diagnosis of 𝐒𝐿. Right? So यहाँ पे तो bacterial ulcer का option नहीं है. That's why it made the thing much easier. But do not think that just because contact lens misuser दिया हुआ है मुझे 𝐒𝐿 mark करना है. No, contact lens misuser may be commonest ulcer is caused by Pseudomonas. It's a bacterial keratitis. But because they have given us a ring ulcer, that's why now we are sure that it is 𝐒𝐿 keratitis. Now, what is the drug of choice for 𝐒𝐿 keratitis? The drug of choice for 𝐒𝐿 keratitis is PHMB. PHMB stands for polyhexamethylene biguanide. PHMB or polyhexamethylene biguanide. So this is the drug of choice for 𝐒𝐿 keratitis. PHMB eye drops. Right? Let's go to the next question. A patient complains of inward deviation of the left eye and diplopia, and there is a face turned to the left side. So there is an inward deviation of the left eye. Inward deviation of the left eye का क्या मतलब है? That is left eye esotropia. Esotropia. Inward deviation of the left eye means left eye esotropia. So the question says that the left eye has esotropia and there is a face turned to the left side. Now let's have a look at this image. So देखो ये right eye है and left eye है. So whenever this is a 3-gaze photograph. So when you have a 3-gaze photograph, the first picture is the primary position. The first picture is our primary position. The second picture, this is your right gaze. ये right gaze है. And the left one, this is the left gaze. This is your left gaze. The third picture, this is your left gaze. So the first one is primary position. So primary position में हमें क्या दिख रहा है? When what we see in the primary position is that the left eye is deviated inwards, or there is a left eye esotropia, and that's also mentioned in our question. In the right gaze, what do we see? When you look at the right gaze, you actually see that the movements are normal. Right gaze में movements are normal. Now how about the left gaze? Left gaze में हम क्या देख रहे हैं? We see that this eye is moving, but this eye is not moving, है ना? So which is the movement that is not happening in the left eye? Left eye जो है वो इधर तक move होना चाहिए था. It should have moved to that corner, but it has not moved. So what is the movement that is missing in the left eye? What is the movement that is missing in the left eye? The movement that is missing in the left eye is abduction. Yes, there is a limitation of abduction in the left eye. So the left eye should have actually moved to this corner. So the left eye, there is a limitation of abduction. So Abhi, now rethink your answer. Rethink your answer, those of you who have given me an answer. तो हमने क्या क्या देखा है इसमें? लेफ्ट आई में देर इज अ लिमिटेशन ऑफ एबडक्शन, एंड बिकॉज द एबडक्शन इज वीक, दैट्स व्हाई द आई इज डिविएटेड इनवर्ड. सो वी आर हैविंग एन esotropia in the left eye with a loss of abduction in the left eye. So which is the abductor of the left eye? The abductor of the left eye is the lateral rectus, right? So that's why this is left-sided LR palsy. It's left-sided LR palsy, or we can say it is a left-sided sixth nerve palsy. I hope this is clear to you now. ये MR palsy नहीं है, MR palsy नहीं है, it is LR palsy. It's a paralysis of the lateral rectus. So when the lateral rectus is paralyzed, the abduction becomes weak, as a result of which the eye is deviated inwards. So there is limitation of abduction and there is esotropia. And because of this, there is a face turn also to the affected side. So that's what you can see here. So in LR palsy, there is a face turn to the affected side. Right? Chalo, let's go to the next question. A patient complains of inability to open the left eye. On examination, we see that the left eye is deviated downwards and outwards. So this is the clinical picture. So let's look at this. What are the features that you see here? So the question says that there is an inability to open the left eye. Or picture में देखो, there is somebody who's lifting up the lid. Now what does this suggest? This suggests that there is a severe ptosis, है ना? There is a severe ptosis. That's why somebody is pulling up the lid. Then what do you see? You see that the eye is deviated down and out, as is given in the question. Eye is down and out. And what else do we see in the picture? Look at the pupil in the left eye and compare it to the right eye. In the left eye, you see that the pupil is dilated. You see that there is a dilated pupil. So these are the features of third cranial nerve palsy. So these are the features of third cranial nerve palsy. Correct. So quickly एक बार third nerve palsy को revise करते हैं. What are the muscles which are supplied by the third nerve? Which are the muscles which are supplied by the third nerve? In the lid, it supplies the LPS, which is the main elevator of the lid, है ना? So it supplies the levator palpebrae superioris in the lid, and therefore, in case of third nerve palsy, we end up with a severe ptosis. We end up with a severe ptosis. Next, it supplies the sphincter pupillae muscle, and it supplies the ciliary muscle intraocularly. It supplies the sphincter pupillae and it also supplies the ciliary muscle. So because it supplies the sphincter pupillae, that is why, because the sphincter pupillae is paralyzed, you are getting a dilated pupil. And because the ciliary muscle is paralyzed, you will get a loss of accommodation. We will get a loss of accommodation. And it supplies all the extraocular muscles. It supplies all the extraocular muscles except the SO and the LR. Now, because all the extraocular muscles are paralyzed except the SO and the LR, that is why the eye is deviated downwards and outwards. So that's why the eye is deviated downwards and outwards. Downwards, why? Because the SO is a depressor. SO जो है वो depressor है, so it pulls the eye down. and LR is an abductor, so it pulls the eye outwards. So the eye is deviated downwards and outwards. So देखो, these are the features of third nerve palsy. We have severe ptosis, we have loss of accommodation with a dilated and fixed pupil, and all the extraocular muscles are lost except SO and LR. Now SO क्या है? SO is a depressor, so it pulls the eye down, and LR is an abductor, so it pulls the eye out. So the eye is deviated downwards and outward. So this is actually third cranial nerve palsy, which is given to us in this image. So question में भी बोला गया है, see there is an inability to open the left eye. Picture में भी we see a severe ptosis. Question also says that the eye is deviated down and out. It is also visible in the image. And in the image we also get to see that the pupil is dilated. Okay, so this is why it is third nerve palsy. Let's go to the next question. Next question be kind of similar ही है. So this question says that the patient complains of mild drooping of the eyelid in the left eye. So if we look at this picture, what do we see? We see that there is a mild ptosis. So there is a ptosis which is mild, and it's also given in the question. There is no ocular deviation. The eye is straight. There is no ocular deviation. The eye is straight. And what can we see about the pupil? If I compare it with the pupil of the right eye, what can we see? We see that there is meiosis, that is the pupil is constricted. So there is a mild ptosis, there is no ocular deviation, and the pupil is constricted. So this is actually Horner syndrome. Now please keep in mind कि हमेशा Horner syndrome नहीं रह सकता है option में. You can have the technical name also. What is the technical name? The technical name of Horner syndrome is oculosympathetic palsy. Oculosympathetic palsy. And here in case of Horner syndrome, we have mild ptosis, we have meiosis, and the third feature is actually anhidrosis. But anhidrosis obviously हमें image में नहीं दिखेगा. We will not be able to see the anhidrosis in the image, but what we can make out in the images, we can make out ptosis and meiosis. So that's why the answer is Horner syndrome. Right? Chalo. Let's go to the next question. The next question is this. A patient complains of jumbling of letters while reading. Now, jumbling of letters while reading means that there is a diplopia in down gaze, basically. This is another way of saying that the patient has diplopia in down gaze. Now, diplopia in down gaze, when you get in a question, the answer, it is likely to be SO palsy, that is superior oblique palsy or fourth nerve palsy. Because the SO is actually a depressor. So diplopia in down gaze, or if they mention that there is difficulty in reading, there is difficulty in climbing down the stairs, difficulty in reading, writing, or climbing down the stairs, all this is suggestive of diplopia in down gaze, and this points to the diagnosis of SO palsy or fourth nerve palsy usually. तो यहाँ पे देखो राइट एसो पाल्सी है, लेफ्ट एसो पाल्सी है ऑप्शन में, तो उन दोनों में से हमको किसी एक को चूज करना है. अभी क्वेश्चन है कि राइट एसो पाल्सी मार्क करना है या लेफ्ट एसो पाल्सी. सो सी व्हाट इज द फीचर ऑफ एसो पाल्सी. इन एसो पाल्सी व्हाट डू यू हैव? द टू मेन फीचर्स दैट यू हैव टू रिमेंबर इज एसो पाल्सी, इट गिव्स राइज टू हाइपरट्रोपिया विथ एक्सटॉर्शन. So on the affected side, there is going to be hypertropia with extorsion, and there is going to be a head tilt to the opposite side. These two things you remember. So features of SO palsy, these two. In the question, they will either mention diplopia in down gaze, or they will say there is jumbling of letters or difficulty in reading and writing, or they will say that there is a difficulty in climbing downstairs. If these are mentioned, then you can safely think that ये एसओ पाल्सी का क्वेश्चन है. अभी हमें ये सोचना है कि राइट एसओ मार्क करना है, लेफ्ट एसओ मार्क करना है. सो एसओ पाल्सी में what do you look for? It is in SO palsy you have hypertropia with extortion and head tilt to the opposite side. So यहाँ पे if you look at this picture, if you look at this question, what does it say? It says that there is a hypertropia in the right eye. So basically hypertropia is in the right eye and the head tilt is to the opposite side, which is the left side. So left जो है वो opposite side है. ठीक है, लेफ्ट जो है दैट इज द ऑपोजिट साइड. So therefore, it's a hypertropia in the right eye, and there is a head tilt to the opposite side, which is the left side. So therefore, the answer is right SO palsy. So the answer is right SO palsy. Okay, shall we go to the next question? Identify the refractive error from the prescription. So -2 sphere, -3 cylinder, 180 degrees. So what is the refractive error from this prescription? -2 sphere, -3 cylinder, 180 degrees. How do we identify? Correct. So what is there in this prescription? In this prescription, see, we have both a concave sphere as well as a concave cylinder. So there is a concave sphere, that is -2 sphere, and there is also a concave cylinder. Both are there, na? So if you have both concave sphere as well as concave cylinder, correct, this is compound myopic astigmatism. It is compound myopic astigmatism or CMA. Compound myopic astigmatism or CMA. Correct. So basically, see, if you have something like this, so if you have only a concave sphere like this, what is this? This is only a concave sphere. If you have only a concave sphere, then this is actually simple myopia. This is simple myopia. If you have only a concave cylinder, meaning if you have a prescription just like this, where you have only a concave cylinder, if there is only a concave cylinder, now this is a prescription of SMA, simple myopic astigmatism. Now, if we have a combination of both, like for example, if I say -3 sphere, if there is a combination of both, as we have in this question, that is -3 sphere and say -1 cylinder cross 90. So in this prescription, see, we have both a concave sphere as well as a concave cylinder. We have both a concave sphere as well as a concave cylinder. So if we have both a concave sphere as well as a concave cylinder, this is CMA. This is compound myopic astigmatism. So if I have only a concave sphere, it is simple myopia. Only a concave cylinder, it is SMA. And if I have both a concave sphere as well as a concave cylinder, it is CMA. Now, how do you decide whether this is WTR or ATR? See, if you have a minus cylinder cross 180, then this is with the rule. The opposite of this is against the rule. So if you have a minus cylinder cross 180, this is with the rule. So this is actually with the rule. If it is a minus cylinder cross 180, then that is with the rule. Right, now the same thing can also be extrapolated to plus prescriptions. So if you look at plus prescriptions, so till now I have discussed minus prescriptions. Suppose you have something like this, like you have say +2 diopter sphere. So if you have +2 diopter sphere, what is this? This is a convex sphere, right? So if it is a convex sphere, then this is a simple hypermetropia. If it is a convex sphere, it is a simple hypermetropia. Suppose you have something like this, say +1 diopter cylinder cross 90. What is this? This is only a convex cylinder. So that's only a convex cylinder. So if it is only a convex cylinder, it is SHA, simple hypermetropic astigmatism. Now if we have a combination like this, a combination of both a convex sphere as well as a convex cylinder, then this is a compound hypermetropic astigmatism. This is CHA. Okay, so this is a combination of a convex sphere as well as a convex cylinder. So if it's a combination of both convex sphere and convex cylinder, this is CHA. And how do you decide WTR or ATR for plus prescriptions? If you have a plus cylinder cross 90, so this is with the rule WTR and the opposite is against the rule. If we have a plus cylinder cross 90, that is with the rule. The opposite is against the rule. So for minus, I told you that if it is a minus cylinder cross 180, that is with the rule. Minus cylinder cross 180 is with the rule. Similarly, plus cylinder cross 90, this is with the rule. Opposite is against the rule. ठीक है, तो इतना हमें याद रखना है फॉर द एग्जाम. बाकी तो ऑफ कोर्स देयर इज अ लॉट ऑफ थियरी विच वी हैव प्रीवियसली डिस्कस्ड. नाउ बिकॉज दिस इज द लास्ट फेज, आई एम जस्ट ट्राइंग टू असिमुलेट द इंपॉर्टेंट इंफॉर्मेशन दैट यू नीड टू रिमेंबर. ठीक है, अब अगर तुम्हारे पास ऐसा प्रिस्क्रिप्शन है, सपोज यू हैव अ प्रिस्क्रिप्शन लाइक दिस, से -2 sphere and +4 cylinder cross 90, or you have say +2 sphere -4 cylinder cross 90. That is, you have a prescription where there is a combination of plus and minus. So the sphere is minus and the cylinder is plus, or the sphere is plus and the cylinder is minus. So if you have a cylinder and a sphere which are of opposite signs, when the cylinder and the sphere are of opposite signs and also the absolute value of the cylinder is greater than the sphere. So if you have the absolute value of the cylinder is greater than the sphere and the cylinder, they are of opposite signs, and the absolute value of the cylinder is greater than the sphere. Because यहाँ पे देखो जो cylinder है, if I just ignore the sign, the cylinder is 4 and the sphere is 2. So the absolute value of the cylinder is greater than the sphere. अगर ऐसा है, so then this is a picture, this is a prescription of mixed astigmatism. So if the sphere and the cylinder are of opposite signs, meaning there is a minus sphere with a plus cylinder, or there is a plus sphere with a minus cylinder, the sphere and cylinder are of opposite signs and the absolute value of the cylinder is greater than the sphere, then this is a prescription of mixed astigmatism. Okay, so this is about glass prescriptions. Shall we go to the next question? Chalo, identify this refractive error. So this is an image based question on refractive errors. So you see these are the parallel rays of light. They have come in as a single bundle, but after refraction, instead of meeting at one focal point, they are meeting at two focal points. So let us name this focal point as F1 and this as F2. So if we have two focal points, that means that it is astigmatism. So what astigmatism is this? Here see one of the two axes, that is F1 here is emetropic because F1 is meeting on the retina. Whereas the other axis F2, this is hypermetropic. So one axis is meeting on the retina and the other axis is meeting behind the retina. So one axis is emetropic and the other axis is hypermetropic. So correct, this is called as simple hypermetropic astigmatism. So one axis is normal or emetropic and the other axis is hypermetropic. This is SHA, simple hypermetropic astigmatism. Okay, shall we go to the next one? A patient presents with difficulty to see on the right side. Perimetry shows the following field defect. So perimetry is showing this field defect. So first of all, what is this field defect? So what is the field defect that we see? See, this is the right eye, this is the left eye. Whenever we get a perimetry printout, we have to mark out the right and the left, and we have to mark out the nasal and temporal. So see, the inner part is nasal, the outer part is temporal. So what do we see in this image? You see that the nasal field of one eye and the temporal field of the other eye are affected. So the nasal field of one eye and the temporal field of the other eye means what? It means that this is called as homonymous hemianopia. So the nasal field of one eye and the temporal field of the other eye means this is homonymous hemianopia. And homonymous hemianopia, where do we get? We get homonymous hemianopia when there is a lesion in the optic tract. So lesion in the optic tract, we get homonymous hemianopia. Now please do not confuse this with bitemporal hemianopia. Bitemporal hemianopia जो है ना, वो ऐसा होता है. So if I get the temporal field of both eyes are affected, this is bitemporal hemianopia. So if the temporal field of both eyes are affected, this is going to be called as bitemporal hemianopia. The other name for bitemporal hemianopia is heteronymous hemianopia. So the other name for bitemporal hemianopia is heteronymous hemianopia. And where do we get bitemporal or heteronymous hemianopia? When the site of the lesion is the optic chiasma. So for optic chiasma, we get bitemporal or heteronymous hemianopia where the temporal field of both eyes are lost. In this picture, we are getting homonymous hemianopia. And how about the occipital cortex? In occipital cortex lesion also, we are going to get a homonymous. But the central part is going to be clear. So what do we call this? What is the defect if there is a lesion in the occipital cortex? If there is a lesion in the occipital cortex, it is homonymous hemianopia with macular sparing. So homonymous hemianopia with macular sparing, that is what we see when there is a lesion in the occipital cortex. Okay? So very, very important images and very, very important one-liners also. Chale to the next question. Chalo. A patient is brought with complaint of severe headache and projectile vomiting. The neurological examination is normal. Visual acuity, color vision are normal. But ophthalmoscopy shows bilateral hyperemic disc with edema and blurred margins. So, complaint of headache and projectile vomiting. So, this is suggestive of raised intracranial pressure. It is suggestive of raised ICT. And what do you get when there is a raised ICT? You get bilateral papilledema, right? So papilledema, see, it is showing hyperemic disc edema with blurred margins. So a patient presents to us with headache and projectile vomiting. This is suggestive of raised ICT. And here what do we get? We get papilledema. In papilledema, what is important to note is that the vision, the color vision, the pupillary reaction and the anterior segment are all normal. And what do you see? The only signs that we see are in the posterior segment. And what do we see in the posterior segment? Bilaterally, you will get to see a hyperemic disc. The disc is edematous and the margins are blurred. So what is the investigational choice here? The investigation that is to be done is an MRI of brain actually. MRI of brain will show us to help us to find out the cause of the raised ICT. We can also do a perimetry. What do you get to see in a perimetry? In perimetry, papilledema shows enlargement of the blind spot. It shows enlargement of the blind spot. But this exactly has no extra relevance because it doesn't get us any further or closer to the diagnosis. So when the patient comes with headache and vomiting and we have seen papilledema, perimetry is not going to give us any extra information. It will show us an enlargement of the blind spot, that's all. But if we want to find out the cause of the raised ICT, we have to do an MRI of brain. So that is our investigation here. Correct. So shall we go to the next question? Very, very, very commonly asked question. A 3-month-old child is brought with complaint of watering from the right eye. So what is this? A child brought with complaint of watering. This is congenital dacryocystitis or congenital NLD block. Congenital dacryocystitis or congenital NLD block. So here the only thing that is to be looked for in the question, what is it? It is the age of the child. So here see the age of the child is less than 1 year. So that's why the answer is sac massage. So for children who are less than 1 year of age, the management is generally conservative. It is sac massage, which is also called as your Krigler's massage, Krigler's hydrostatic massage. So you ask the mother to massage the area of the sac, and with this pressure, the lower end of the NLD gets opened. Because in congenital dacryocystitis, the site of obstruction is the valve of Hassner. Again, another important MCQ. The valve of Hassner. Let's go to the next question. So what is the next question? Identify this procedure. So what is the procedure that's being shown here? The procedure that's being shown here, correct. This is applanation tonometry. This is the Goldman applanation tonometer. So this is the Goldman applanation tonometer. Now Goldman applanation tonometer, this is the gold standard tonometer. This is the Goldman applanation tonometer. This is the gold standard tonometer. And here what you have to do is you have to stain the tear film with fluorescein dye, and you have this procedure. This is done under the cobalt blue filter of the slit lamp. So all these are commonly asked questions. So here you stain the tear film with fluorescein dye. You do the examination under the cobalt blue filter of the slit lamp. So that's why see the background light is blue, and you make this applanation by prism touch the surface of the cornea. This is how applanation tonometry is done, and this is Goldman applanation tonometer, which is the gold standard tonometer. Next question. A child presents, a 2-year-old child, presents with leukocoria. Leukocoria means white pupillary reflex. On examination, there is detachment, total retinal detachment in the right eye, and the USG-B scan shows mass with calcification, an intraocular mass with calcification. And this is the mass that you can see here. So what are the key words in the question? It's a 2-year-old child, presents with white pupillary reflex, and there is a mass with calcification. Correct. So all this points to the diagnosis of retinoblastoma. This is retinoblastoma. So important points to remember about retinoblastoma. Retinoblastoma, the presenting age is around 1.5 to 2 years. The presenting feature is leukocoria, that is white pupillary reflex. Please remember that there may be other malignancies also associated with retinoblastoma. So the other malignancies associated with retinoblastoma may be osteosarcoma. They may present with osteosarcoma. The most common route of spread of retinoblastoma. The most common route of spread of retinoblastoma is direct spread via the optic nerve to the brain. Direct spread via the optic nerve. Via the optic nerve. Now the investigation of choice is generally MRI of orbit and brain. But if MRI is not available, you do a USG-B scan. And when you do a USG-B scan, what do you get to see? You get to see an intraocular mass with calcification. You get to see an intraocular mass with calcification. Now, the gene most commonly responsible for retinoblastoma is the RB gene, and the location of the gene is 13q14. So these are the important points to remember. So see, in this question, they have given us that the age of the child is 2 years, presents with white pupillary reflex, and USG-B scan is showing an intraocular mass with calcification. So 2-3 important pointers are there, and we have this mass. So that's why this is nothing but retinoblastoma. Commonly asked question in the exam. Right, shall we go to the next question? A child presents with retinoblastoma which is involving more than 50% of the globe. Now, what is the treatment? For a retinoblastoma which is involving more than 50% of the globe, what is the treatment? For retinoblastoma which is involving more than 50% of the globe, the treatment is enucleation. Now, what is enucleation? Enucleation means removal of the eyeball with a portion of the optic nerve. So the most common route of spread is via the optic nerve. So that's why you remove the globe with a portion of the optic nerve. This is enucleation. Removal of the eyeball with a portion of the optic nerve. Now please remember that for retinoblastoma, we have 2 types of questions that come. If they say it's an intraocular retinoblastoma, intraocular means it is confined to the globe. If it is more than 50% of the globe, as is given in this question, if it is more than 50% of the globe, then it is enucleation. Then it is enucleation. If it is less than 50% of the globe, then we don't go for enucleation. Then the treatment is focal therapy. Then the treatment is focal therapy. If it is more than 50%, it's enucleation. Less than 50%, the answer is focal therapy. Now, what are the options of focal therapy? Focal therapy options are, it can be laser therapy, it can be cryotherapy, or it can be brachytherapy. Laser therapy, cryotherapy, or brachytherapy. Okay, so in this question, it is more than 50%. So that's why it is enucleation. And where do you give chemotherapy? Chemotherapy, this is for retinoblastoma with metastases. So when you have retinoblastoma which has spread to the distant organs, then the treatment for that is chemotherapy. Retinoblastoma with metastasis agar hai na, then the answer is chemotherapy. Okay? Let's go to the next question. Which of the following statements is not true about fungal corneal ulcer? Now, fungal corneal ulcer is something that you have to know like the back of your hand. इसको हमें बिल्कुल बहुत ही अच्छे से जानना है. इसमें कभी भी कोई भी mistake नहीं होना चाहिए. So, which of the following statements is not true about fungal corneal ulcer? So, trauma with vegetative matter, well-defined margins. Natamycin is the drug of choice in India, and we have a fixed hypopion. So, isme se which one is wrong? The answer is well-defined margins. Well-defined margins are seen in a bacterial corneal ulcer, whereas in fungal corneal ulcer, the margins are typically described as feathery, fuzzy, or ill-defined. Feathery, fuzzy, or ill-defined margin. Feathery, fuzzy, or ill-defined margins. So trauma with vegetative matter, that is true. So in case of a fungal corneal ulcer, the symptoms, they tend to be less pronounced than a bacterial corneal ulcer. There is often a preceding history of trauma with vegetative matter. The margins are typically described as feathery, fuzzy, or ill-defined. The hypopion is fixed, meaning it is immobile, and it is often non-sterile. Non-sterile means that if you were to aspirate that hypopion, you would get fungal hyphae. And also the ulcer is like this. There is usually one small ulcer, and surrounding it there are smaller lesions. These smaller lesions, they are called as our satellite lesions. They are called as satellite lesions. And natamycin is the drug of choice in India. Why is natamycin the drug of choice in India? Because ulcers in India are mostly caused by aspergillus, and aspergillus is very sensitive to natamycin. So that's why. So all these are right. So what is wrong is well-defined margins. Well-defined margins are seen in a bacterial corneal ulcer. In a fungal corneal ulcer, we will get feathery, fuzzy, or ill-defined margins. Okay, commonly asked PYQIA. Next, corneal transparency is maintained by all except arrangement of the stromal fibers, hydration of the cornea, unmyelinated nerve fibers, या avascularity. So see, arrangement of stromal fibers, ये तो correct है, because this is the regular arrangement of the stromal fibers is one of the most important causes for corneal transparency. The nerve fibers are unmyelinated, that's also correct. Avascularity is also correct. So what is wrong is hydration. It is not the hydration, it is the dehydration of the cornea, correct? So it's the dehydration of the cornea. Now, who maintains the dehydration of the cornea? So, the dehydration of the cornea, this is maintained by the sodium-potassium ATPase pump of the corneal endothelium. The sodium-potassium ATPase pump of the corneal endothelium, it maintains the cornea in a state of dehydration. And this dehydration is actually responsible for the transparency of the cornea. So if the sodium-potassium ATPase pump is not properly functional, and then the cornea becomes hydrated and edematous, and if it becomes hydrated and edematous, it actually loses its transparency. So corneal transparency is maintained not by hydration but by the dehydration. Yeah. Okay. Next question. Identify this chart. What is the name of this chart? So first of all, see, we understand that this is a visual acuity chart. How do we know that it's a visual acuity chart? Because as you go down, the size of the letters is decreasing. So the letters are biggest in the topmost line, and as you go down, the size of the letters is becoming smaller, right? And what is the other special feature? You see that the number of letters in each line is the same. So the number of letters in each line is the same. So every line has got 5 letters. Every line has got 5 letters. So this is the ETDRS chart. The ETDRS chart, this is a visual acuity chart. How do we know it's a visual acuity chart? Because as you go down, the size of the letters decreases. So in the top, the letters are big, and as you go down, the size of the letters is becoming smaller. So that's how we know it's a visual acuity charts. And how do we know that it's an ETDRS chart? Because the number of letters in each line is the same. Every line has got 5 letters. So this is your ETDRS chart. Now what is the full form of ETDRS chart? Bailey-Lovie chart, correct. The other name is Bailey-Lovie chart, and ETDRS stands for Early Treatment Diabetic Retinopathy Study Chart. Early Treatment Diabetic Retinopathy Study Chart. So it was used in this study, and that's why it was used. It has been named like that. So Early Treatment Diabetic Retinopathy Study Chart, and that's why the name ETDRS. But as you correctly told me, the other name for the chart is Bailey and Lovie chart. Correct. Now, what is the use of the Pelly-Robson chart? The Pelly-Robson chart is what? The Pelly-Robson chart is the contrast sensitivity chart. The use of the Pelly-Robson chart is it's a contrast sensitivity chart. And what is the use of the Ishihara chart? Ishihara chart is your color vision. Ishihara chart, this is the color vision. Okay, let's go to the next one. What is this? This is very, very simple. Correct. This is your Ishihara chart. So this is the Ishihara chart, and Ishihara chart, this is used for evaluation of color vision. So we have to remember that the Ishihara chart, it helps us to evaluate only red-green color deficiencies. It helps us to identify only red-green color deficiencies. All types of color deficiency is not going to be picked up by this chart. The commonest type of color abnormality that we know is actually red-green, and red-green anomalies are picked up by the Ishihara chart. Okay, shall we go to the next one? A patient who uses -7 and -10 glasses in both eyes presents with complaint of flashes and floaters. What is to be done next? So reassure the patient and send him home. Retinoscopy, direct ophthalmoscopy, indirect ophthalmoscopy. So what do we see? He's using -7 and -10, meaning he's a myope. He's a myope, right? He's presenting to us with complaint of flashes and floaters. So flashes and floaters in a myopic patient, they may be suggestive of a peripheral retinal tear. They may be suggestive of a peripheral retinal tear. So a patient who is a myope presenting to us with flashes and floaters, matlab, it may be suggestive of a peripheral retinal tear. So what do you do if a peripheral, how do you examine the peripheral retina? The instrument for evaluating the peripheral retina is the indirect ophthalmoscopy. So what do we have to do is we do an indirect ophthalmoscopy. Why? Because you have to identify the tear. You have to find the tear. So you do an indirect ophthalmoscopy to identify the tear. And if you are able to find the tear, then you close the tear with laser, that is called as laser barrage. So if you identify the tear, you just close the tear with laser, that is called as laser barrage. Okay, so a myopic patient presenting to us with sudden onset flashes and floaters, this may be suggestive of a peripheral retinal tear. So if I want to examine the peripheral retina, what do I have to do? I have to do indirect ophthalmoscopy. I identify the tear and I close the tear with laser. Now, why it is not direct ophthalmoscopy? Because direct ophthalmoscopy allows me to see only the central retina. What do I mean by the central retina? Central retina means that I can see only the optic disc and the macula. With the direct ophthalmoscope, I can see only the optic disc and macula. I cannot see the periphery. So there is no use of doing a direct ophthalmoscopy. And why not retinoscopy? Because I have told you many times before also, the name of the retinoscope is actually retinoscope, but it's almost like a misnomer because it is not meant for evaluation of the retina at all. The function of the retinoscope is actually refraction. So यहाँ पे हमें refraction तो करना ही नहीं है. We have to evaluate the peripheral retina, right? So that is what is needed here. So there is no use of retinoscope. ठीक है? This is an important PYQ. It has come many times in different exams. Let's go to the next one. Again, another common PYT. A 60-year-old patient, meaning an elderly patient who has a history of heart disease, is presenting to us with sudden loss of vision. And this is what we see. So, elderly patient presenting with a sudden severe vision loss. And what do we see here? We see cherry red spot. What is cherry red spot? See, the whole retina is appearing to be edematous and pale, and it's only the fovea which appears bright red. So you can see the fovea here. Only the fovea is appearing bright red. This is what we call typically as cherry red spot. So what is the diagnosis? Elderly patient presenting with sudden loss of vision and there is a cherry red spot. This is CRAO, correct? Central retinal artery occlusion. Now, what are the treatment options for CRAO? Now, in CRAO, what do? The idea is you suddenly lower the intraocular pressure. And when you do that, it is said that if you suddenly lower the IOP, this creates a jerk effect and the jerk may help to dislodge the thrombus. So, the methods are vigorous ocular massage, intravenous mannitol, paracentesis. So, vigorous ocular massage. If you do a vigorous ocular massage, it helps in the outflow of aqueous humor and the pressure will fall. Intravenous mannitol, provided the patient does not have any heart disease. So in this patient, that's not an option because it's a patient of heart disease. And we have paracentesis. Paracentesis means aspiration of aqueous from the anterior chain. And we also give inhalation of carbogen. Why? Because carbogen is a vasodilator. So these are the treatment options for CRAO. Vigorous ocular massage, mannitol if the patient is not a patient of cardiovascular disease, paracentesis and carbogen inhalation. So उसमें से यहाँ पे क्या है? Yes, ocular massage and paracentesis. This is our answer. Okay, shall we go to the next question? A 60-year-old patient, so an elderly patient, history of hypertension, presents with sudden loss of vision. 60-year-old patient, history of hypertension, presents with sudden loss of vision. And what do we see in the fundus? So the whole fundus or the whole retina is full of hemorrhages. And what is this appearance typically called? This is typically what is called as our splashed tomato appearance. This is typically what is called as our splashed tomato appearance. So the whole retina is full of hemorrhages, correct? So this is CRVO, central retinal vein occlusion. So if you have a cherry red spot, that is CRAO, central retinal artery occlusion. And if we have this kind of hemorrhages throughout the fundus, this is splashed tomato appearance, which is CRVO. Chalo, next question. A 35-year-old male patient, meaning young male patient, history of smoking. There is a sudden decrease in vision and metamorphopsia. On examination, there is a localized neurosensory detachment. And if you do an FFA, it shows smokestack pattern. So see, what are the key words in the question? It's a young male patient who has a history of smoking. The patient is presenting to us with distortion of vision, that is metamorphopsia. So either it can be micropsia, that is objects appear to be smaller, or it can be metamorphopsia. And what do you see? You see that there is a localized detachment of the neurosensory retina only in the posterior pole. So only here in the posterior pole, there is a localized neurosensory retina detachment. And if an FFA is done, it is showing smokestack pattern. So this is typically what we call as CSCR or CSR, central serous chorioretinopathy. The new name is CSCR, that is central serous chorioretinopathy. The old name is CSR. It is CSR. Now, what are the risk factors for CSR? The three risk factors of CSR, they are remembered by the three S's: smoking, stress, and steroids. Smoking, stress, and steroids. So, steroids are to be avoided at any case in this patient. So, smoking, stress, and steroids. So, steroids are contraindicated in this. Okay, chale, next question. A patient is diagnosed with high risk PDR in both the eyes. What should be the line of management? So for PDR, what is our first line of management? For PDR, the first line of management is pan-retinal photocoagulation or PRP. So for proliferative diabetic retinopathy, the first line of management for PDR is pan-retinal photocoagulation or PRP. Correct, pan-retinal photocoagulation or PRP. Now students always confuse this with option number D, that is only glycemic control. Please remember, glycemic control with no ocular management, this is the treatment for NPDR. So if they say their patient presents with NPDR in both the eyes, what should be the line of management? Then the answer will be that no ocular treatment is to be given and only glycemic control is to be done. But the moment they say that it is PDR, in the PDR stage, the ocular management has to start and the treatment is PRP, pan-retinal photocoagulation. Okay? Next question. A 10-year-old boy is brought with complaint of difficulty in night vision. So see night blindness or nyctalopia. On examination, the fundus shows pale disc with bony spicules. So pale disc with bony spicules and night blindness together, this gives us a diagnosis of retinitis pigmentosa. This together gives us a diagnosis of retinitis pigmentosa. Now, retinitis pigmentosa, this is a dystrophy of the rod cells. It's a dystrophy of the rod cells, right? So, because the rod cells are responsible for night vision, that's why in retinitis pigmentosa, the patient is presenting with night blindness or nyctalopia. Now, retinitis pigmentosa may be sporadic, meaning there is no family history, or it can be inherited also, and all types of inheritance patterns are possible. All types of inheritance patterns are possible here. You can have autosomal dominant, autosomal recessive, as well as X-linked. And here, yes, as the question tells us, nyctalopia is the presenting complaint, and the triad of signs. What is the triad of signs? This again is important for exam. The triad of signs is disc pallor, which is mentioned in the question. Attenuation of the arterioles, that is the blood vessels are thin. So arteriolar attenuation. And the third is bony spicules or bony corpuscles. So disc pallor, arteriolar attenuation and bony spicules or bony corpuscles, this is the triad of signs. And the investigation of choice is ERG. ERG stands for electroretinogram. Now, electroretinogram, which are the normal waves of the ERG? The normal waves of the ERG are, there is a down wave which is called as the A wave, and this A wave arises from the photoreceptors. And there is an up wave which is called as the B wave, which arises from the bipolar and the Muller's cells. So this is your normal ERG. So which wave of ERG is actually affected? It is the A wave. So in case of retinitis pigmentosa, the A wave of ERG is affected. in retinitis pigmentosa, that is in RP. A wave is affected because A wave arises from the photoreceptors, and what happens to the A wave? There is a decrease in the amplitude of this A wave. So this A wave is not as sharp as it is in a normal case. You get a decrease in the amplitude of the A wave in case of retinitis pigmentosa. Right? So shall we go to the next question? Sure. This is our next question. So what is this? What is this picture? You get to see this kind of a shiny blackish patch at the macula. So this shiny blackish patch at the macula, this is called as the beaten bronze appearance of the macula. This is called as the beaten bronze appearance of the macula, and this is typically what we get to see in case of Stargardt's disease. Stargardt's disease, beaten bronze appearance of the macula. So Stargardt's disease, it has autosomal recessive inheritance, and it is a dystrophy of the RPE, which there is a dystrophy of the RPE. And because it affects the macula, the patients have poor vision since childhood, and you have this kind of a shiny appearance of the macula, which is called as the beaten bronze appearance of the macula. Right? So, let's go to the next question. All of the following are true regarding the condition in the picture except. So it causes myopia, it is associated with UV ray exposure, it's more common nasally, and recurrence is common after excision. So what is the condition in the picture? So you see this kind of a fold of conjunctiva growing onto the surface of the cornea. Correct, this is a pterygium. Now pterygium, we all know this is more common on the nasal side. It is associated with UV ray exposure, and that's why it is seen in farmers and in outdoor workers. And the treatment of pterygium is excision, but recurrence is common. So all this is correct. So what is wrong is this, that it causes myopia. It doesn't cause myopia. What is the refractive error it causes? It causes astigmatism. How does it cause astigmatism? See, it is growing on the horizontal axis of the cornea. So it flattens the horizontal axis, as a result of which the vertical axis becomes more curved. So it causes astigmatism. How? It flattens the horizontal axis of the cornea. It flattens the horizontal axis of the cornea. So the vertical axis becomes more curved than the horizontal. So this is how it causes astigmatism. It doesn't cause myopia. It is associated with UV ray exposure. That's why it is seen in rural populations, in farmers, in laborers who work outdoors. It is more common on the nasal side. And if you do a simple excision, then the main problem that happens is recurrence. So we are often asked which is the best method to prevent recurrence. It is excision with conjunctival autograft. Excision with CAG. CAG stands for conjunctival autograft. Now what is conjunctival autograft? Conjunctival autograft means that you take a piece of conjunctiva of the same size from the same eye from another site and you put it here. So we measure the defect of the conjunctiva, we harvest a piece of conjunctiva from the same eye from another site and we put it here. So excision with conjunctival autograft or CAG, this is the best method to prevent recurrence. The other method of preventing recurrence is by application of mitomycin C. But mitomycin C is in itself quite a toxic drug, so it's not very commonly preferred. So what is the best method or the most preferred method to prevent recurrence? If we are asked, we have to say excision with conjunctival autograft. चलिए next question पे. Chalo, let's come to the next question. So what is our next question? Next question says that a 14-year-old patient presents with frequently changing glasses. So what is the complaint? It's frequently changing glasses. On examination, look at the retinoscopy. Retinoscopy is -9 sphere, -7 cylinder, 115 degrees. So it's a myopic astigmatism, and this myopic astigmatism does not improve with glasses. Why it doesn't improve with glasses? Because it is a type of irregular astigmatism. So it is irregular astigmatism because you can see it's a myopic astigmatism. There is -9 sphere, so there is a myopia, and there is also a minus cylinder. So it's a myopic astigmatism. But this myopic astigmatism is not improving with glasses. And see, look at the clinical picture. What do you see? What is the clinical picture when the patient is asked to look down? See, the protruded cornea is indenting or pressing the lower lid. So what is this sign? I think all of you know this is your Munson's sign. This is the Munson sign. That is, on looking down, the protruded cornea presses or indents the lower lid. This is your Munson's sign. So the diagnosis, correct. The diagnosis here is keratoconus. The diagnosis here is keratoconus. What is the investigation of choice for keratoconus? The investigation of choice is actually corneal tomography. But if tomography is not available, then you can do the second best one, that is topography. So यहाँ पे tomography तो वैसे option में है ही नहीं, so that's why we are choosing topography as our option. So corneal topography, that is the answer. Okay, chalo. Identify the procedure that has been done here. So you can see a picture of the retina. And what do you see here? You see multiple yellow dots. So what are these yellow dots? These yellow dots, these are our laser marks. So you can see that laser has been done 360 degree. This is PRP, pan-retinal photocoagulation, which we just learned, which is done for proliferative diabetic retinopathy. So you do this for proliferative diabetic retinopathy, pan-retinal photocoagulation or PRP. So this is a picture of PRP. Let's go to the next question. Very often repeated question. A patient 2 years post cataract surgery presents with gradual onset decrease in vision. So cataract has already been done for this patient, and about 2 years after that he is complaining of decrease in vision. And see, it looks behind the IOL, you get this kind of a whitish opacity. So this whitish opacity, what is this called? This is called as posterior capsule opacification or PCO. This is posterior capsule opacification or PCO. And posterior capsule opacification is the most common late complication of cataract surgery. So this is the most common late complication. This is the most common late complication of cataract surgery, where sometimes months or sometimes years after cataract surgery, the patient presents with this kind of an opacity. Where is this opacity? Actually, it's in the posterior capsule. Meaning, see, inside this capsular bag is my intraocular lens. I have done the cataract surgery, I have put the IOL in the capsular bag, but behind this IOL, the posterior capsule has become opaque. So as a result, the light is once again getting blocked. So what do I have to do? I have to create a cruciate opening at the center of the posterior capsule with the help of laser. So if I create an opening here at the center of the posterior capsule, it will allow the light to pass. So the diagnosis is PCO. The old name for PCO was after cataract. Now it's not called after cataract anymore. Now it's called PCO. But previously it was called after cataract. And how do you treat it? You treat it by creating a cruciate opening at the center of the posterior capsule. This is called as laser capsulotomy. Otomy means to make an opening. So this is done with Nd:YAG laser. So it's called as Nd:YAG laser capsulotomy. Nd:YAG laser capsulotomy. Again, another often repeated PYQ. Chale next question pe. Chalo, let's go to the next question. Identify this step in cataract surgery. So look at this image. What is exactly being done here? Yes, an opening, a circular opening is being created in the anterior capsule, correct. So this is called as capsulorhexis. And to make the capsule visible, because the capsule is actually transparent, to make it visible, the anterior capsule, it is stained with a dye. So what is the name of the dye? The anterior capsule, it has been stained with trypan blue dye. Yes, the anterior capsule has been stained with trypan blue dye. That's why it's appearing blue. And then you are using this capsulorhexis forceps. So what is this? This is the capsulorhexis forceps. You're using the capsulorhexis forceps to create a circular opening in the anterior capsule. So this is what we mean by hydrodissection. This is what we mean by capsulorhexis. So you stain the anterior capsule with trypan blue dye, and then with the help of the capsulorhexis forceps, you create a circular opening in the anterior capsule. This is capsulorhexis. The next step is hydrodissection. Let's go to the next question. What is the instrument? The instrument in the picture is used in cataract surgery to enter the lens, the anterior chamber, the posterior chamber, or the sclera. So this is a blade. All of you can make out what is this blade. It's a sharp-edged cutting blade. The name of this blade is keratome blade. The name of this blade is keratome blade. So it is a sharp-edged cutting blade which is called as the keratome blade. So what is the keratome blade made to used for? It is created for making the clear corneal incision. It is meant for creating the clear corneal incision. And what you do with the help of the clear corneal incision? With the help of the clear corneal incision, from the cornea you enter into the anterior chamber. Right? You are creating an incision where? From the cornea into the anterior chamber. That's the purpose of the incision. So this sharp cutting edge blade, that is the keratome blade, helps us to enter through the cornea into the anterior chamber. So that's why this is our answer. Okay? Chale, next question. What is the instrument in this picture used for which step in cataract surgery? So पहले बताओ ये instrument कौन सा है? Yes, this is the phacoprobe, or this is the phacoemulsification probe. This is the phacoemulsification probe, and this phacoprobe, I have told you that this phacoprobe, it has an ultrasound tip. What is the use of this ultrasound tip? The ultrasound tip is meant to hit and emulsify the nucleus. That is, it breaks the nucleus into many small pieces. It hits the nucleus and it emulsifies the nucleus, meaning it breaks it into multiple small pieces. And these tubings, they are connected to the vacuum pump of the phaco machine. This is connected to the vacuum pump of the phaco machine. So the tip actually emulsifies the nucleus and the vacuum pump aspirates the nucleus. The tip emulsifies and the vacuum pump, it aspirates the nucleus. So what exactly is this? This is the main step of phacoemulsification cataract surgery, that is the management of the lens nucleus. So it is used for phacoemulsification, that is emulsification and aspiration of the lens nucleus. Right? Chalo. Let's go to the next question. Identify this surgery. First of all, what is the step? So here what you see is, you see this kind of an instrument, this kind of an instrument here, right? This instrument that you see here, this is called as the irrigating wire vectis. This is the irrigating wire vectis. What does the irrigating wire vectis do? This is actually small incision cataract surgery. Now, small incision cataract surgery is actually a manual surgery. So therefore, there are no fancy equipment. Because there is no fancy equipment, we have a much larger incision. The size of the incision in SICS is 6 to 6.5 mm. Whereas in modern day cataract surgery, that is phacoemulsification cataract surgery, the size of the incision is less than 3 mm. Now, why do I have a small a less than 3 mm incision in phaco? Because as we saw here, you have this phaco probe, and this phaco probe, it emulsifies the nucleus, meaning it breaks the nucleus into many small pieces, and those small pieces are actually aspirated with the help of the vacuum pump. So that's why in case of a phacoemulsification cataract surgery, even if my nucleus is big, it's removed through a much smaller incision. However, in case of SICS, it's a manual surgery. So you don't have this fancy equipment, which is your phaco machine. So you have to remove the nucleus in toto. So that's why you have a much larger incision. So what you do is, through this large incision, which is the 6.5 mm incision, you put in this wire vectis. So the front end of the wire vectis, it is shaped like a spoon. So what it does is it picks up the nucleus and you drag it out through the incision. So this is called as your nucleus delivery in SICS. Why we are calling it nucleus delivery? Because the whole nucleus is removed as a whole. So this instrument is the wire vectis. It goes within the nucleus. You pick it up like a spoon and then you drag it out through the incision. The incision is big enough to allow the passage of the nucleus. It's about 6 to 6.5 mm. So this is SICS, small incision cataract surgery. Why it is called SICS? Because it has the smallest incision among all the manual surgeries. There are 3 manual surgeries: ICC, ECC and SICS. So out of these manual surgeries, it has the smallest incision. समझ आया ना? चलो, let's go to the next question. A 60-year-old patient, that is an elderly patient, notices an improvement in near vision with his right eye, and the refraction in the right eye has changed from -1.5 to -4. तो इसका क्या मतलब है? That there is a myopic shift, right? So a myopic shift in an elderly patient. Why should an elderly patient develop a myopic shift, and what is this myopia called? This myopia is called as index myopia. Why? Because it is caused by an increase in the refractive index of the lens, which is seen in case of nuclear cataract. So nuclear cataract, what is happening? The center of the nucleus, it becomes more dense, and so there is an increase in refractive index. This causes a myopic shift. Now, because of this myopic shift, there is a sudden improvement in near vision. And what is this called? This is called as your second sight of old age. So all these are features of nuclear cataract. So what are the features of nuclear cataract? In nuclear cataract, the center of the lens nucleus, it becomes more dense. As a result, there is an increase in refractive index. Because of the increase in refractive index, there is a myopic shift in refraction, which is called as index myopia. And because of the index myopia, the patients notice a significant improvement in near vision, which is called as your second sight. Right? So this is about this question. So let us do something. Let us take a short break of 5 minutes. I will be back in 5 minutes and then we will continue with the rest of the questions, because otherwise it will become too heavy for you. Just take a short break of 5 minutes, फिर वापस आते हैं and then we'll start with the next question. So hi everyone, shall we start again? So let's just look at this question. So see, it says that a patient presents with bilateral superotemporal subluxation of the lens. A patient presents with bilateral superotemporal subluxation of the lens. So now what is the possible diagnosis? So where also we have been given this image. So अगर हम इस image को देखेंगे, so what do we see in this image? We see, yeah, that they should have given us in this image that this is the left eye of the patient. And left eye का मतलब है ये nasal है, ये temporal है. So we see that superotemporal subluxation है, which is also given to us in the question. So the answer is Marfan. And this Marfan, this is the most common cause of ectopia lentis. Ectopia lentis का मतलब है abnormal lens position since birth. So abnormal lens position since birth or ectopia lentis is the most common cause of ectopia lentis is Marfan, and the position of the lens in Marfan is superotemporal. Now just to quickly revise, what is the position of the lens in homocystinuria? The position of the lens in homocystinuria is inferonasal. The position of the lens in homocystinuria, it is inferonasal. Inferonasal subluxation is seen in homocystinuria, superotemporal in Marfan. Chale, next question. A patient presents with a cataract that is shown to us in the picture. He may develop which of the following complications? So what is the cataract that is shown to us in the picture? So see, we can see a sunken nucleus here. Why do we see a sunken nucleus? Why is the nucleus sunken? Because the cortex here is liquefied. So we see that the peripheral cortex is all liquefied, and because the cortex is all liquefied, that is why the nucleus is sunken to the bottom. So this is a hypermature Morgagnonian cataract. So this is a hypermature Morgagnonian cataract. And what do we see? What is the main complication of the hypermature Morgagnonian cataract? In a hypermature Morgagnonian cataract, the liquefied cortex, it leaks out and it blocks the pores of the trabecular meshwork, right? So this liquefied cortex leaks out and blocks the pores of the trabecular meshwork, and this is called as the phacolytic glaucoma. That's called as phacolytic glaucoma. So liquefied cortex leaks out and blocks the pores of the trabecular meshwork. Please remember that the other name for phacolytic glaucoma is lens protein glaucoma. So that's why kabhi kya karte hain, they don't give phacolytic, they can give lens protein glaucoma also in the option. Now often what students do, they confuse it with phacomorphic. So please remember, phacomorphic kahan pe hota hai? Phacomorphic is seen in a mature and intumescent cataract. Now what is the meaning of the word intumescent? Intumescent refers to a swollen lens. So this swollen lens or this intumescent cataract pushes the iris forward and closes the angle. That is phacomorphic. So phacomorphic means it is a type of secondary angle closure glaucoma. So this is a type of secondary ACG, angle closure glaucoma, where the swollen lens pushes the iris forward and closes the angle. However, this Morgagnonian cataract, here the liquefied cortex leaks out and blocks the pores of the trabecular meshwork, and this is phacolytic glaucoma, which is a type of secondary open angle glaucoma. Phacomorphic is secondary ACG, phacolytic is secondary OAG. Please remember this. Chale? Next question. A patient complains of glare and halos with difficulty in vision in bright light and reading. So complain of glare and halos, difficulty in vision in bright light and reading means that is in constricted pupil. Difficulty in vision in constricted pupil. So that means that this cataract is right at the center. So you have glare and halos with a cataract right at the center here. This is typically what we call as posterior subcapsular cataract. Because the cataract is right at the center, that's why it blocks the light when the pupil is small. That is when you are reading or in bright light. So difficulty in vision in bright light or reading, that is with a constricted pupil and associated with glare and halos. This is typically what is posterior subcapsular cataract. Next one. A 25-year-old patient presented to the OPD with a history of myopia. So the patient is myopic. He is using -2 in the left eye and -3 in the right eye. He sent for retinoscopy. What is the expected movement of the retinal reflex in the right eye? Now see, this is a 25-year-old patient, meaning his power is likely to be stable. मतलब कि उसका अभी भी शायद रिफ्रैक्शन ऑलमोस्ट सेम ही आएगा, -2 in the left and -3 in the right. And we know that, and they have not mentioned any cycloplegic. They have also not mentioned the distance of refraction. So we have to assume that the distance is a standard distance, that is 1 meter, and there is no cycloplegic. Right? And in both eyes, you see that there is a myopia which is greater than -1. So when the distance is 1 meter, there is no cycloplegic and the myopia is more than -1, what are we going to get? What is the expected movement? The expected movement is against movement, right? So against movement means that the reflex is going to move opposite to the direction of the retinoscope. It's going to move opposite to the direction of the retinoscope. So the catch in the question is that they have said that it's a 25-year-old patient, which means that the refraction is likely to be stable. It's going to be -2, -3 only. They have not mentioned the distance, so we assume the standard distance and there is no cycloplegia. So when there is no cycloplegia for a distance of refraction of 1 meter, if the myopia is more than -1, we are going to get against movement. So here, both in the right eye as well as in the left eye, not just in the right eye, even in the left eye, the myopia is more than -1. So in case of left eye also, I am going to get against movement only. Okay? Next. A 45-year-old patient is able to see clearly for distance but not able to read small print. So there is a difficulty of vision for near. The distance vision is good, but the near vision is affected. So near vision is affected whenever we get a question. There are two options. Either the answer can be hypermetropia or it can be presbyopia. Now here the answer depends on what is the age of the patient that is given. So if the age of the patient is greater than equal to 40 years, this means that there is a problem in accommodation and the answer is going to be presbyopia. But if the age of the patient is less than 40 years, then we are supposed to mark hypermetropia as the answer. Right? So please keep this in mind that whenever you get a question which says that there is a problem or there is a difficulty in near vision, always look at what is the age of the patient mentioned in the question. If the age of the patient mentioned is greater than equal to 40 years, then our answer is presbyopia. And if it is less than 40 years, we have to mark hypermetropia as our answer. Right? Chalo, let's go to the next question. What are the muscles which are acting in this position? What are the muscles acting in this position? So see, this is your right eye, this is the left eye. So what is this? See, the patient is looking to the left side. That means this movement or this position is levoversion. This is levoversion. Levoversion means what? Levoversion means that the left eye abducts. The left eye abducts. And the right eye adducts, right? There is left eye abduction and there is right eye adduction. So if the left eye abducts, which is the muscle, that means that the left eye, the lateral rectus, and the right eye adduction means right eye medial rectus. So levoversion means left eye abduction, right eye adduction. So left eye lateral rectus, right eye medial rectus. These are the yoke muscles. So left eye lateral rectus, right eye medial rectus. So this set of muscles which are working in this conjugate movement, these are our yoke muscles. Next question. From the picture, what is our diagnosis? What is the diagnosis from this picture? So first of all, what is this test? The name of this test is Hirschberg test. The name of this test is Hirschberg test. The name of the test is Hirschberg test. This is a test for tropia, that is manifest squint. This is a test for tropia, which is also called as manifest squint. So see, this is your right eye, this is the left eye. In the right eye, the reflection of the torch is at the center of the pupil, which means that the right eye is actually normal. So the problem is in the left eye. So in the left eye, you see that this is the position of the reflection. So what is the deviation in the left eye? You understand that the left eye is deviated inward. So it is esotropia. And where is the reflection? The reflection is at the limbus. So if the reflection is at the limbus, then the amount of deviation is 45 degrees. So see, look at the reflection that is falling in the right eye. The reflection of the torch is right at the center of the pupil. That means the right eye has no deviation. The right eye is normal. In the left eye, the reflection of the torch is falling on the outer side. So if it's falling on the outer side, that means that the eye is deviated inwards. So that's why left eye, you can make out from the picture also that it's a convergent squint. It's an inward deviation. That is, it is ESO. Now, how do you know how much of ESO? Because it is at the limbus, we have to assume that the ESO is around 45 degrees. Now, if the reflection had been somewhere here, that is, if the reflection had been at the pupillary margin, so at the pupillary margin, how much is the amount of deviation? If it is at the pupillary margin, then the amount of deviation is around 15 degrees. At the limbus, it's 45 degrees as it is there in the question. If it is at the pupillary margin, it's going to be 15 degrees. So here it is 45 degrees. And अगर midway है तो it is 30 degrees. Yeah, अगर pupillary margin और limbus के midway हमारा reflex है, then it's going to be around 30 degrees. चलिए next question पे. A patient of known sulfur allergy presents with glaucoma. Which of these drugs is contraindicated in the patient? So the answer is yes, acetazolamide. The answer is acetazolamide. So see, acetazolamide belongs to the grade of carbonic anhydrase inhibitors. It belongs to the group of carbonic anhydrase inhibitors, and under the carbonic anhydrase inhibitors we have systemic as well as topical members. We have systemic members and we have topical members. The systemic member is this, that is acetazolamide. The topical members are dorzolamide and brinzolamide. The topical members are dorzolamide and brinzolamide. Okay, so all these zolamides, they are all sulfur containing drugs. All these carbonic anhydrase inhibitors, they are sulfur containing drugs. They are chemically sulfonamides. So these carbonic anhydrase inhibitors, they are chemically sulfonamides. So acetazolamide, dorzolamide, brinzolamide, they are all chemically sulfonamides, meaning they are sulfur containing drugs. That's why they must not be given in sulfur allergy, because if given in sulfur allergy, they have the potential to precipitate Stevens-Johnson syndrome. Okay, next question. A patient is able to read only the largest letter on the Snellen's chart. How would you record the visual acuity? So the topmost letter. So what is the topmost letter? The topmost letter, if the patient reads, which is usually an E. If the patient reads the topmost letter, the visual acuity is 6 by 60. Then next line is what? Next line is 6 by 36. Then comes 6 by 24. Then 6 by 18. Then 6 by 12. Then 6 by 9. Then 6 by 6. And this 6 by 6 is what we call as normal visual acuity. So 660, 636, 624, 618, 612, 69, 66. This 66 is what is called as normal visual acuity. It is also written as 20 by 20. So if the patient is able to read only the largest letter, that is only the topmost line, that means the visual acuity is 6 by 60. And another very important thing to remember, what is the meaning of this 6 by 60? It means that this letter should be seen by a normal person. Should be seen by a normal person from a distance of 60 meters. The letter should be seen by a normal person from a distance of 60 meters. From a distance of 60. Letter should be seen by a normal person from a distance of 60 meters. That is what we mean by 6 by 60. Next question. What is the dose of vitamin A for a 1-year-old child? The dose of vitamin A for a 1-year-old child. Now this is also something you have to know like the back of your hand. इसको हम गलत नहीं कर सकते हैं. So greater than equal to 1 year or greater than equal to 8 kgs, our dose is 2 lakh international units to be given orally on days 0, 1, 14. So 2 lakh international units to be given orally on days 0, 1, 14. And for less than 1 year or less than 8 kgs, our dose is 1 lakh international units to be given orally, and the dose regimen remains the same, 0, 1 and 14. Now this is your oral dose. So oral dose is 2 lakh and 1 lakh. But there is also an intramuscular dose, and please remember the intramuscular dose is half of the oral dose. The regimen is the same, day 0, day 1, day 14, but the IM dose is half of the oral dose. So यहाँ पे देखो हमें क्या बताया गया है, 2 lakh international units on days 0, 1 and 14. So this is our, so 2 lakh international units on days 0, 1 and 14. Chale to the next question. Which of the following is not a type of electrophysiological investigation? So which is not electrophysiological? So देखो electrophysiological are VEP. Where do we give VEP? This is used in the diagnosis of optic neuritis, visual evoked potential. Here you record the electrical activity from the occipital cortex. Electroretinogram, this is used in the diagnosis of mainly retinitis pigmentosa. It is also used in the diagnosis of siderosis bulbi, that is iron foreign body in the eye. Siderosis bulbi, iron foreign body in the eye, causing changes in the eye. Electrooculogram is another electrophysiological disease. This is used in the diagnosis of Best's disease. So these are the ocular electrophysiological tests. So we have VP, where you record the electrical activity from the occipital cortex. ERG, where you record the electrical activity from the retina. Electrooculogram, also you record the electrical activity from the eye only. It's an uncommon investigation used in the diagnosis of Best's disease. So see, fundus fluorescein angiography, it's not electrophysiology, it is used to study the blood vessels of the retina. So this is a type of angiography. It is used, see, it can be used in diabetic retinopathy. It can be used in the diagnosis of central serous retinopathy, recurrent CSCR. So anywhere where you want to study any defects of the blood vessels, there you use this angiography, that is FFA. So it's not a type of ocular electrophysiology. Chale, next question. All of the following are true about LASIK except age must be more than 18 years, preoperative thickness must be evaluated, refraction should be stable for 1 year prior to the surgery, and it is a lens-based refractive surgery. So I think all of you know that yes, what is the prerequisite for the refractive surgery? For any refractive surgery, the age has to be more than 18 years and the refraction should be stable for the past 1 year, right? But LASIK, this is not a lens-based refractive surgery. This is a cornea-based refractive surgery. So LASIK and PRK, LASIK, PRK, these are cornea-based refractive surgeries. They are cornea-based refractive surgeries. Where what do you do? Here the shape of the cornea is changed with the help of laser, and the laser that is used here is called as your excimer laser. So LASIK and BRK are cornea-based refractive surgeries where the shape of the cornea is changed with the help of laser. The laser that is used in LASIK and BRK is called as excimer laser. And when you do excimer laser, then the final corneal thickness is actually less than the initial corneal thickness. So the thickness of the cornea decreases, which means that evaluation of preoperative corneal thickness is a must. Because if the preoperative cornea is already very thin, then the patient may not be the right candidate to go for a LASIK or a PRK. So that is why it's important to evaluate the preoperative corneal thickness. So ये सब तो correct ही है. What is wrong is that it's a lens based refractive surgery. ये lens based नहीं है, ये cornea based है. Which is the lens based refractive surgery? The name of the lens based refractive surgery is phakic intraocular lens. So what is phakic intraocular lens? In phakic intraocular lens, a corrective lens is placed in the eye in front of the crystalline lens. Mind you, it's not like cataract surgery. In cataract surgery, you remove the lens and you place an artificial lens. Here, an additional lens is placed. That is, in front of the existing crystalline lens, you are placing a corrective intraocular lens. That is phakic intraocular lens. So, phakic IOL is the type of lens-based refractive surgery. Cornea-based refractive surgeries कौन से हैं? Cornea-based refractive surgeries are LASIK, PRK, which is done with excimer laser, and the newer form is SMILE surgery. SMILE surgery is also a cornea-based refractive surgery, but it is not done with excimer laser, it is done with femtosecond laser. So as I said, LASIK PRK, here the shape of the cornea is altered with the help of excimer laser. In SMILE surgery, the laser that is used is femtosecond laser. So these are our cornea-based refractive surgery. Lens-based refractive surgery is phakic intraocular lens. Okay, let's go to the next question. Identify the instrument. So instrument कौन सा है? See, there is a handle. On top of the handle, there is a head. And there is a dial here at the shaft. This is a retinoscope. And what's the use of the retinoscope? I told you a little while ago. The use of the retinoscope is refraction. It is meant for doing refraction. So do not confuse it with the name. इसका नाम भले ही रेटिनोस्कोप है. This is not meant for evaluation of the retina. रेटिना इवेल्युएशन के लिए जो इंस्ट्रूमेंट होता है उसका नाम है ऑफ्थेल्मोस्कोप. तो उसका नाम ऑफ्थेल्मोस्कोप है बट इट इज यूज फॉर रेटिना इवेल्युएशन. इसका नाम रेटिनोस्कोप है बट दिस इज नॉट फॉर रेटिना इवेल्युएशन, इट इज फॉर रिफ्रैक्शन. चलिए नेक्स्ट क्वेश्चन. चलो, all of the following are true about the ciliary body except. All of the following are true about the ciliary body except it is responsible for accommodation, it is divided into pars plicatum and pars plana, aqueous humor is produced from the pars plana, and it is a part of the middle vascular coat of the eyeball. So which of the following is not true? Yes, so you know that the ciliary body, it's a part of the middle vascular coat. The middle vascular coat consists of the iris, the ciliary body and the choroid. So the ciliary body is a part of the middle vascular coat. It is divided into pars plicatum and pars plana. It is responsible for accommodation and it also is responsible for production of aqueous humor. But aqueous humor is not produced from the pars plana, it's produced from the pars plicatum. Actually, the anterior part of the ciliary body, it has these projections. These projections, this is responsible for the formation of aqueous humor. So these are called as your ciliary processes, and the ciliary processes are a part of the pars plicatum. So these ciliary processes or these projections, they are a part of the pars plicatum. So aqueous humor is not produced from the pars plana, it is produced from the pars plicatum. Simple question. चलो नेक्स्ट क्वेश्चन पे चलते हैं. आर्जिल रॉबर्टसन प्यूपल. व्हाट इज ट्रू अबाउट आर्जिल रॉबर्टसन प्यूपल? व्हाट इज आर्जिल रॉबर्टसन प्यूपल? आर्जिल रॉबर्टसन प्यूपल इज डिस्क्राइब्ड वेयर? आर्जिल रॉबर्टसन प्यूपल इज डिस्क्राइब्ड इन न्यूरोसिफिलिस. It is described in neurosyphilis and the site of the lesion is the pretectal nucleus. So pretectal nucleus याद करो क्या है? Pretectal nucleus, this is the center for the light reflex. The pretectal nucleus is the center for the light reflex. So what happens if the pretectal nucleus goes? So if the pretectal nucleus goes, then the light reflex will go. So the light reflex is absent. The light reflex goes. But what about the near reflex? The center for the near reflex is in the ventral midbrain. So even if the pretectal near nucleus goes, the near reflex will remain. So the near reflex will remain. Okay, so near reflex is present. So shall I go over this once more? Argyll-Robertson pupil classically described in neurosyphilis. Here there is a lesion in the pretectal nucleus, which is the center for the light reflex. So if the pretectal nucleus goes, the light reflex will obviously go, but the near reflex will remain because the center for the near reflex is located in your ventral midbrain. So this condition where the light reflex goes but the near reflex remains, this is called as light near dissociation. So Argyll-Robertson pupil, this is light near dissociation. Now students often confuse it with RAPD, relative afferent pupillary defect जो है ना, the other name for RAPD is Marcus gun pupil. The other name for RAPD is Marcus gun pupil, and we see this when there is a lesion in the optic nerve. This is seen when there is a lesion in the optic nerve. Marcus gun pupil or RAPD is seen if there is a lesion in the optic nerve. Okay, next question. What is the diagnosis from this picture? So this picture mein, what do we see? We see a child without glasses and we see a child with glasses. So look at the child without the glasses, look at the left eye. What do you see in the left eye? You see an esotropia. The eye is showing a convergent squint in the left eye. But the moment you wear the glasses, give the glasses, there is orthotropia. Orthotropia with glasses. So there is esotropia without glasses and there is orthotropia with glasses. This is typically seen in accommodative esotropia. So accommodative esotropia is seen in children with uncorrected high hypermetropic refractive error. So children who have high uncorrected hypermetropic refractive error, because if there is excess of hypermetropia, what will happen? There will be too much of accommodation. And accommodation is accompanied by convergence. So too much of accommodation leads to too much of convergence. As a result of this, there is accommodative esotropia. So children with uncorrected high hypermetropia may develop esotropia. This is called as accommodative esotropia. So how is it treated? It is treated with glasses. So when you give glasses, the hypermetropia gets corrected, the excess accommodation gets corrected, and so there is the child becomes orthotropic. This is accommodative ESO. Right? Let's go to the next question. What is the cause of the cataract that is seen in the picture? So first of all, let us identify कि ये cataract कौन सा है. So you see there is a flower shaped cataract here. This flower shaped cataract, this is called as rosette cataracts. Correct. This is the rosette cataract. And where do we get to see this kind of a flower shaped or a rosette cataract? Flower shaped or rosette cataract, this is seen in trauma. Now what kind of trauma? What kind of trauma is it? It is blunt trauma. Good. It is blunt trauma. So this is a flower shaped cataract or rosette cataract which is seen in blunt trauma. The other types of cataract we discussed in the when we did the question on myotonic dystrophy and Christmas tree cataract, right? So I think we can move on to the next question. Where do we get to see sudden and painless loss of vision? So देखो sudden and painless loss of vision में what are the options given to us? Vitreous hemorrhage, acute iridocyclitis, Stargardt's disease and angle closure glaucoma. So where do we get sudden and painless loss of vision? See, sudden and painless loss of vision is seen in vitreous hemorrhage. Now acute iridocyclitis and acute angle closure glaucoma, they cause sudden loss of vision but it's extremely painful. It's a sudden and painful loss of vision. Sudden and painful loss of vision. And both of them, it's a painful red eye. They present with a painful red eye. So acute iridocyclitis meaning acute anti-uveitis and acute ACG, sudden painful loss of vision and it's a painful red eye. And Stargardt's disease where you have a beaten bronze appearance of the macula, it's a type of retinal dystrophy. And here you have a gradual and painless loss of vision. It's bilateral, gradual and painless loss of vision. Gradual, painless loss of vision and it's often bilateral. It's bilateral. So vitreous hemorrhage is sudden and painless. It's unilateral generally, and it is a sudden and painless loss of vision. Identify the incorrect match. Just give me 1 second. Give me 1 minute. Just 1 minute, I'm sorry. Identify the incorrect match. Unilateral papilledema, Foster-Kennedy syndrome, Usher syndrome, retinitis pigmentosa, limbal dermoid, golden hair, and shield ulcer, Flicktenular. So I think all of you know shield ulcer, Flicktenular is wrong. Why? Because where do you get to see shield ulcer? Shield ulcer is seen in VKC, vernal keratoconjunctivitis. It is seen in VKC, vernal keratoconjunctivitis. Others are correct. Limbal dermoid is associated with golden hair. Usher is associated with retinitis pigmentosa. It is a combination of RP with deafness. And what is Foster-Kennedy syndrome? Foster-Kennedy syndrome is where you have ipsilateral optic atrophy. It is a condition which is seen in olfactory lobe tumors. It is seen in olfactory lobe tumors where you have ipsilateral optic atrophy and you have contralateral papilledema. So see, it's a unique syndrome where, because papilledema by definition is bilateral. So ipsilateral optic atrophy and contralateral papilledema. This is Foster-Kennedy's. Okay? Next question. Which of the following statements is incorrect? External hordeolum, that is stye, is an acute infection of the gland of Zeiss. Internal hordeolum is an acute infection of the meibomian gland. Chalazion is a chronic inflammation of the gland of Zeiss, and meibomian gland may cause dry eye. So what is wrong? Wrong is this. Chalazion is not an infection of the gland of Zeiss. Chalazion is a chronic granulomatous inflammation of your meibomian gland. It's a chronic granulomatous inflammation of the meibomian gland. External and internal hordeolum are acute infections. Stye is for the gland of Zeiss and internal hordeolum for the meibomian gland. And meibomian gland disease, why does it cause dry eye? Because this meibomian gland, it forms the outer lipid layer of the tear film. It is responsible for forming the lipid layer of the tear film. So if the meibomian gland is affected, you get what is called as evaporative dry eye. So this lipid layer is deficient and you end up with excessive evaporation, which is called as evaporative dry. So this is also correct. चलिए next question पे चलो identify the instrument. Simple one liner. This is a Chalazion clamp. This is a Chalazion clamp. So you use this for incision and curettage of the Chalazion. So this is used for INC. The Chalazion clamp is meant to fix the Chalazion and then you make a vertical incision. Then with the help of the scoop you remove all the material. So this is the Chalazion clamp. Next, what is trichiasis? Trichiasis obviously means misdirected eyelashes. It means misdirected eyelashes. We have learned this is in physto, that is in trachoma, follicles, inflammation, scarring, trichiasis, and corneal opacity. So we have seen it in the physto classification of trachoma. Trichiasis means misdirected eyelashes. And what is second row of eyelashes called? What is second row of eyelashes called? Second row of eyelashes, this is called as distichiasis. This is called as distichiasis. And what are depigmented eyelashes called? Depigmented eyelashes, this is called as poliosis. This is called as poliosis. Depigmented eyelashes is poliosis. Next question. Which of the following is not a side effect of latanoprost? So latanoprost belongs to which group? It belongs to the group of prostaglandin analogues. So which are the prostaglandin analogues that we have? We have latanoprost, we have travoprost, and we have bimetoprost. Latanoprost, travoprost, and bimetoprost. And what is their mechanism of action? They increase the uveoscleral outflow. They increase the uveoscleral outflow, and that's how they are used as an anti-glaucoma drug. They increase the uveoscleral outflow, and as a result they decrease the intraocular pressure, and that's how they are used as anti-glaucoma drugs. Now what are the side effects? The side effects are iris pigmentation, hypertrichosis, and cystoid macular edema. So which of them is not a side effect? It is lid retraction. Now lid retraction, this is a side effect of the alpha receptor agonist, that means brimonidine and apraclonidine. It is a side effect of the alpha receptor agonist, that is brimonidine and apraclonidine. They cause lid retraction. For PG analogues, lid retraction is not a side effect. Next question. According to the WHO criteria for blindness, the presenting visual acuity in the better eye should be less than. What is the answer here? According to the WHO criteria, what should be the presenting visual acuity? It should be less than 3/60. Yes, that is counting fingers at 3 meters. So if the presenting visual acuity in the better eye is less than 3/60, then that, according to WHO, this is a criteria for blind. The criteria for blind. Chalo, next one. Which type of refractive error is treated with this lens? अभी ये lens कौन सा है? So in this lens, what do you see? You see that there is +2 written here in one axis, and in the other axis there is only a line. So this here in this axis there is no power. Right? So +2 is written in one axis, and in the other axis there is no power. So this means that this lens has power only in one axis. It has power only in one axis. So this is what kind of lens? It is a cylindrical lens, correct? So it's a cylindrical lens. अब cylindrical lens का क्या मतलब होता है? Cylindrical lens is used in the treatment of astigmatism. It is used in the treatment of astigmatism. So ये जो है, this is not a spherical lens. If it is a spherical lens, there will be power in both the axes. So this is a +2 diopter cylinder. It's a plus lens, it's a convex lens, but it's not a sphere. It's a cylinder because एक ही axis पे power है, दूसरे axis पे power नहीं है. And where do we use cylindrical lenses? Cylindrical lenses are used in the treatment of us. Next question. Identify this investigation. So this is FFA, fundus fluorescein angiography. So here fluorescein dye is injected into the patient's vein. You wait for the dye to reach the retina, and then you take pictures of the retina. So you can see the dye inside the retinal blood vessels. So you will be able to delineate or study the retinal blood vessel. So this FFA, it is mainly used for the study of retinal blood vessels. So you can use it for studying diabetic retinopathy. It is used in the study of CSCR, that is central serous retinopathy. Many other retinal vascular diseases, wherever you want to study the vasculature of the retina, this can be used. So this is FFA, fundus fluorescein angiography. Chale, next question. What is the diagnosis from this clinical photograph? So you can all make out this is an optic disc. But what is the problem with this optic disc? Look at the cup, the size of the cup. So you see that the cup is so big. Normally क्या होता है? If this is the optic disc, this will be the cup. And you see the blood vessels like this. And what is the normal CD ratio? The normal CD ratio is in the order of 0.3 to 0.5:1. So the normal CD ratio जो है, that's the normal CD ratio. The normal CD ratio is 0.3 to 0.5:1. But here, see, the cup is much bigger. So here you have an increased CD ratio. Your cup is much bigger, the cup is large. So there is an increased CD ratio. So where do you get an increased CD ratio? Increased CD ratio is seen in glaucoma. So normally the CD ratio is 0.3 to 0.5. But here the CD ratio is much more than that. So an increased CD ratio, this is suggestive of glaucomatous optic atrophy or glaucoma. Okay, chalo, next question. The most recent advancement in the field of cataract surgery is, so the most advancement in the field of cataract surgery is FLACS. What is the full form of FLACS? FLACS stand for femtosecond laser assisted cataract surgery. Femtosecond laser assisted cataract surgery. So femtosecond laser assisted cataract surgery. So therefore we can understand that the most recent one is the use of femtosecond laser. Femtosecond laser assisted cataract. Next question. What is anisometropia? Anisometropia means what? Anisometropia means difference, a significant difference in the refractive error between the two eyes. And what is the problem with anisometropia? If you give glasses to an anisometropic person, there will be a significant difference in the image size between the two eyes, and this is called as aniseikonia. It is called as aniseikonia. So significant difference in the image size of the two eyes, this is called as aniseikonia. So don't confuse the two words. Anisometropia means significant difference in the refractive error between the two eyes, and aniseikonia means significant difference in the image size between the two eyes. And if there is a significant difference in the pupillary size of the two eyes, this is called as anisocoria. This is called as anisocoria. So anisometropia, difference in refractive error; aniseikonia, difference in image size; and anisocoria, difference in pupillary. Next question. A patient has been recently diagnosed with type 1 diabetes. When should be screening for diabetic retinopathy begin? So we all know that if it is for type 1, it should begin 5 years after the diagnosis of diabetes. And if it is type 2, if it is a type 2 diabetes, it is going to start immediately on diagnosis. So if it's a type 1 diabetes, the screening will begin 5 years after the diagnosis of diabetes. And if it's a type 2 diabetes, it is going to begin immediately. We should start the screening immediately on diagnosis of diabetes. Next question. Which of the following is not included in the Global Vision 2020 program? Global Vision 2020. So Global Vision 2020, the diseases included are remembered as CROCT. The first C is obviously cataract. The R is what? I think all of you know. R stands for obviously refractive errors. O is river blindness, that is onchocerciasis. Onchocerciasis is not seen in our part of the world. The next C is childhood blindness. Childhood blindness, and T is trachoma. So cataract, refractive error, onchocerciasis, childhood blindness, and trachoma. Obviously, ROP, retinopathy of prematurity, is not a part of the Global Vision 2020 program. So please remember the names of these diseases: cataract, refractive error, onchocerciasis, childhood blindness, and trachoma. Next question. I know you're getting tired, but we have 100 questions. I think we must be through with 3/4 of them. We have a few more to go. Chalo, let's go to the next question. Which of the following is not a part of the light reflex pathway? Which of the following is not a part of the light reflex pathway? The answer is optic radiation. Now, optic radiation, this is a part of the visual pathway. This is a part of the visual pathway, but it's not a part of the light reflex pathway. Because in the visual pathway, what are the structures in the visual pathway? In the visual pathway, you have the optic nerve, then we have the optic chiasma, then we have the optic tract, then we have the LGB, that is the lateral geniculate body, then we have the optic radiation, and then we have the occipital cortex. right? So this is our visual pathway. So this optic radiation is a part of the visual pathway. Optic nerve, optic chiasma, optic tract, LGB, optic radiation, occipital cortex. However, this is not a part of the light reflex pathway. In the light reflex pathway, you have the optic nerve, you have the optic chiasma, then we have the optic tract. And after the optic tract, it comes to the pretectal nucleus in the dorsal midbrain, which is the center for the light reflex. So it doesn't go from the optic tract to the optic radiation. In the light reflex pathway, it is optic nerve, optic chiasma, optic tract, and then it comes to the pretectal nucleus. So see, this optic radiation is a part of your visual pathway. It's not a part of the light reflex pathway. Chale? Identify the instrument in the picture. Nothing to explain really. This is the slit lamp by microscope. Next question. What is the laser used in LASIK? We just discussed it now. It is the excimer laser. LASIK as well as PRK. That is, both in PRK and LASIK we use excimer laser. Now where is Nd:YAG laser used? See, Nd:YAG laser is used in two important procedures. It is used in laser peripheral iridotomy. It is used in laser peripheral iridotomy. Where do you do a laser peripheral iridotomy? It is done in ACG, that is angle closure glaucoma, and it is also done for laser capsulotomy. It is done for laser capsulotomy. Where do you do laser capsulotomy? Laser capsulotomy is done in PCO, that is posterior capsule opacification. So laser PI and laser capsulotomy, this is done with Nd:YAG laser, and LASIK and PRK, they are done with excimer laser. So don't make a mistake here. Okay? Chale? All of the following are features of NPDR except non-proliferative diabetic retinopathy. So microaneurysm, vitreous hemorrhage, cotton wool spots, dot blot hemorrhages. Very simple question. Answer is vitreous hemorrhage. Why? Because vitreous hemorrhage it comes after neovascularization. It is caused by neovascularization of the retina. So these new blood vessels of the retina, they are the ones which rupture and give rise to vitreous hemorrhage. So this is actually PDR. This is a feature of proliferative diabetic retinopathy. Vitreous hemorrhage is caused by the new blood vessels, the new vascularization of retina. These new blood vessels, they are friable and they are fragile and they rupture, giving rise to VH. So it is not a feature of NPDR, it's a feature of PDR. The others, microaneurysms, cotton wool spots and dot blot hemorrhages, they are all features of NPDR. Next question. Where are the stem cells located? The ocular stem cells are located in the limbus. This is an often asked one-liner. So the limbus, what is the importance of the limbus or these stem cells? They help in regeneration and repair of the ocular surface after any kind of injury. When there is an ocular surface injury, it is these stem cells of the limbus which actually help in regeneration and repair. So that is the importance of the limbus in ophthalmology. Next question. What is the posterior limit of the orbital floor? Now the orbital floor is formed mainly of two bones. The orbital floor in the anterior part, it is made up of the maxilla, and posteriorly it is made up of the palatine bone. It is made up of the palatine bone. So this bone is your maxilla, which is in front, and posteriorly we have the palatine bone. So posterior limit of the orbital floor is made up of the palatine bone. The posterior limit, the anterior limit is the maxilla, not the posterior limit. This is the maxilla which is in front. पीछे maxilla नहीं है, पीछे palatine bone है. So the posterior limit of the orbital floor is not formed by the maxilla, it is formed by the palatine bone. ठीक है? Please don't make this mistake. चल. What is the procedure that has been done here? So the procedure that has been done here is keratoplasty. Keratoplasty means what? Cornea transplantation. Keratoplasty or cornea transplantation. So that is the procedure that's been done here. So देखो ये जो central वाला part है ना, this is the graft. This is the graft. That is the donor cornea. Periphery में this whitish thing that you see, this is the host. That is your recipient. This is the recipient. And these black lines that you see, these are the sutures. So this is a picture of keratoplasty or cornea transplant. Right? The refractive media of the eye are all except aqueous humor, lens, ciliary body, cornea. I think ये तो नींद में भी पूछेंगे तो आना चाहिए, इतना simple है. Answer is ciliary body. Which are the refractive media of the eye? So at first we have the tear film. Tear film के बाद we have the cornea, then we have the aqueous, then we have the lens, and this is the vitreous. So these are the refractive media of the eye. So ciliary body is not a part of the refractive media, certainly. Chalo, let's go to the next question. Which of the following statements is untrue about the sclera? The sclera is an opaque structure. That's correct. It helps in ocular movements because it gives attachment to the extraocular muscles. It transmits the optic nerve posteriorly. Obviously, the optic nerve has to pierce the sclera to move out. So, ये सब correct है. It acts as an identification feature. It is wrong. The identification structure in the eye is actually the iris. The iris pattern and the iris color, the color and the pattern of the iris, they can be used for identification. So sclera का कैसे ही कोई identify करेगा? It is just white in color. तो उससे हम नहीं कर सकते. The iris color, because some people have pigmented iris, some people have hypopigmented iris. Then we have the pattern of the iris. So iris can act as an identifying feature, but it's not the sclera. Correct. You have iris scanners. Iris recognition technology is there. Where do you use cover, uncover test? So, important PYQ, it is used for latent squint, which is called as phoria. Latent squint or phoria. So, remember, manifest squint जो है उसको हम बोलते हैं tropia. And I told you the test for manifest squint is your Hirschberg test. The test for manifest squint is the Hirschberg test, which we saw in a previous question. So the cover uncover test, this is for latent squint, that is phoria. Which of the following statements is true? So, which of them is correct? Inferior oblique is the longest extraocular muscle. This is wrong. Why? Inferior oblique is the shortest extraocular muscles. Oblique muscles arise from the annulus of Zinn. This is also wrong. The rectus muscles arise from the annulus of Zinn. LPS is supplied by the facial nerve. This is wrong. LPS is supplied by the third nerve. So what is correct is this, that Muller's muscle has sympathetic nerve supply. So inferior oblique is not the longest extraocular muscle. It is the SO. The superior oblique is the longest extraocular muscle. Inferior oblique is the shortest of the extraocular muscles. The rectus muscles, they arise from the tendinous ring at the apex of the orbit, which is your annulus of Zinn. LPS is supplied by the oculomotor, that is the third nerve. So all these are wrong. So Muller's muscle has sympathetic supply. This is correct. And that's why the Muller's muscle is affected in Horner syndrome, that is oculosympathetic palsy. Okay? Which of the following is not true about primary congenital glaucoma? Photophobia is a symptom, Habstria seen, thin sclera may be seen, and anterior chamber is shallow. Now remember, what is the triad of symptoms? It is lacrimation, photophobia, and blepharospasm. Lacrimation, photophobia, and blepharospasm. These are the symptoms of primary congenital glaucoma. And what is the most striking sign? The most striking sign is a large globe, that is ophthalmos. So, in case of congenital glaucoma, the globe enlarges and the globe is large in size because of the stretching of the globe. And because of the stretching of the globe, you get stretch lines on the cornea which are called as Habstria. So these Habstria are stretch lines on the cornea, and because of the stretching or enlargement of the globe, the sclera may also become thin. So all these are correct. So photophobia, lacrimation, blepharospasm are the common symptoms. You have a large globe or ophthalmos. You have a large hazy cornea. You have a large hazy cornea with stretch lines called Habstria. The sclera may be thin. All these is correct. What is wrong is anterior chamber is shallow. So anterior chamber is not shallow. You have a deep anterior chamber. Why do we have a deep anterior chamber? Because your globe is large. It's a ophthalmic globe. So it's a large globe. So in the large globe, you will have large chambers. So deep anterior chamber. So please remember that shallow anterior chamber जो है, that is seen in ACG. Shallow AC is seen in angle closure glaucoma. It's not seen in all types of glaucoma. In angle closure glaucoma, I am going to see a shallow anterior chamber. Whereas in congenital glaucoma, it's not a shallow anterior chamber, it's a deep anterior. Okay? Next question. Which anti-glaucoma drug causes drowsiness? The drowsiness, it is caused by brimonidine. Brimonidine jo hai, it has an important side effect. It causes CNS depression, which leads to drowsiness. It causes apnea. CNS depression, drowsiness and apnea, and that is why it is contraindicated in small children. That is, it is contraindicated in children less than 6 years of age. So anti-glaucoma drug causing drowsiness is brimonidine, and this belongs to which class of drugs, do you remember? It belongs to alpha receptor agonist. It belongs to the class of alpha receptor agonist drug. Next question. 𝐒𝐿 appearance of the macula is seen in. ये सबको पता है, it is Best's disease. हमने थोड़ी देर पहले पढ़ा था Stargardt's disease. The appearance is Beaton-Brown's appearance of the macula. So Beaton-Brown's appearance जो है वो Stargardt's में है, and 𝐒𝐿 appearance जो है that is in your Best's disease. That's seen in Best's. Next, the condition in the photograph can be caused by all except. So ये photograph में ये है जो हम देख रहे हैं, ये क्या है? You see these white dots on the corneal endothelium. These are keratic precipitates, and these are large and greasy. They are large, greasy keratic precipitates. These large and greasy keratic precipitates, they are called as what? They are called as mutton fat KPs. And if you get mutton fat KPs, what does it tell you about the diagnosis? Where do you get mutton fat KPs? Mutton fat KPs are seen in granulomatous uveitis. They are seen in granulomatous uveitis. So these are large, greasy KPs or mutton fat KPs which are suggestive of granulomatous uveitis. So यहाँ पे देखो, so the question says it is not seen in where? So see, TB, sarcoid and leprosy are granulomatous. So ankylosing spondylitis जो है, this is non-granulomatous. Here also you get to see KPs, but they are small and fine. So they are not large and greasy like these. So large greasy KPs or mutton fat KPs are seen in granulomatous. यहाँ पे TB, leprosy और sarcoid जो है वो granulomatous है. Ankylosing spondylitis causes non-granulomatous anterior uveitis. So you will get KPs, but they will be small and fine KPs. They will be small and fine KPs, not large and coarse like this. Okay. Next question. What is the diagnosis from the photograph? Simple. You can see what can you see in the lid? This is ectropion. What is ectropion? Ectropion means outward turning of the lid margin. So outward turning of the lid margin. This is ectropion. Outward turning of the lid margin, that is ectropion. Next one. The condition in the photograph is caused by which of the following drugs? अब ये जो photograph है इसमें हमें क्या दिख रहा है? So bilaterally at the macula you see something which looks like this, है ना? ऐसे eye जैसा दिख रहा है ना ये at the macula. Look here and look here. So it looks like an eye. So this is typically what is called as your bull's eye maculopathy. This is what is called as your bull's eye maculopathy, and bull's eye maculopathy is a side effect of long-standing use of HCQ, that is hydroxychloroquine. So what you see here is your bull's eye maculopathy, and bull's eye maculopathy is seen with long-standing use of HCQ or hydroxychloroquine. Chale, next question. Most common ophthalmic manifestation of COVID-19. So COVID-19, the most common ophthalmic manifestation is follicular conjunctivitis. So follicular conjunctivitis is an ophthalmic manifestation of many upper respiratory tract, viral infections also. Not just COVID because, it was, this is something which has like shaken all of us. So that's why we are saying this. But कोविड के अलावा भी अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शंस के साथ एसोसिएटेड फॉलिक्यूलर कंजंक्टिवाइटिस इज क्वाइट कॉमन. सो कोविड भी है तो वही इट्स एन अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शन टू बिगिन विद एंड इट ऑल्सो कॉजेज फॉलिक्यूलर कंजंक्टिवाइटिस. The power of the converging lens that is being used in this procedure. So see, what is this procedure? This is indirect ophthalmoscopy. This is indirect ophthalmoscopy. Right, so when you want to focus the retina in indirect ophthalmoscopy, see the examiner is using this lens in the hand. This is a 20 diopter lens. This is a 20 diopter lens. So with indirect ophthalmoscopy, we use 20 diopter lens. And with your slit lamp bimicroscope, you use the 90D lens. So if you want to see the retina with a slit lamp bimicroscope. See, the slit lamp bimicroscope allows you to see only up to the anterior 1/3 of the vitreous cavity. So if you want to see the posterior part of the vitreous cavity and the retina with your slit lamp, then you have to use this additional lens, which is your 90D lens. So remember, slit lamp के साथ है 90D lens, indirect ophthalmoscope के साथ है 20D lens. So here it is the 20D lens. चलो, which is the most common drug causing cataract? ये हमने थोड़ी देर पहले भी पढ़ा था. It is steroids. Remember, it is systemic steroids. So systemic steroids जो है ना, systemic steroids they are known to cause cataract or toxic cataract or drug induced cataract. Whereas if you have topical steroids, what is the important side effect of topical steroids? Topical steroids tend to cause increase in intraocular pressure, which may lead to steroid-induced glaucoma, which may eventually lead to steroid-induced glaucoma. So याद रखो that systemic steroid से क्या होता है? Systemic steroid से होता है cataract. What type of cataract is it? It is a posterior subcapsular cataract. और topical steroid से क्या होता है? Topical steroids generally cause increase in intraocular pressure and this may eventually lead to steroid-induced glaucoma. Right? Chalo, let's go to the next question. A 25-year-old man presents with severe non-granulomatous uveitis. He has history of similar episodes in both eyes in the past. And he has a history of low back pain for many years. So young male patient, non-granulomatous uveitis, multiple or recurrent episodes and low back pain. So all this together, what does it give us a diagnosis of? It points to the diagnosis of ankylosing spondylitis, है ना? So young male patient है, low back pain है, non-granulomatous anterior uveitis है. So together this gives us a diagnosis of ankylosing spondylitis. So investigation to be done next is HLA-B27. HLA-B27. Now this is an often repeated question, often asked PYQ. So let us look at what are the keywords in the question. It says that there is an elderly female patient presenting with severe pain, sudden onset severe pain and blurred vision. The pain is so severe that there is associated nausea and vomiting. On examination, visual acuity is decreased, eye is red with hazy cornea, shallow anterior chamber and dilated fixed pupil, shallow anterior chamber, dilated fixed pupil, and the eye is stony, hard to touch. Stony, hard to touch का मतलब है IOP is very, very high. So look at the keywords: elderly female patient, sudden onset severe pain, pain is so bad that there may be associated nausea, vomiting, and the eye is angry looking, the anterior chamber is shallow. You can see that the pupil is fixed and the eye is very hard to touch. Correct. This is exactly all the key features mentioned of acute ACG. Acute angle closure glaucoma. Acute angle closure glaucoma. So all the keywords are there. So these are the keywords that we have to pick up from the question. Let's come to the next question. Identify the procedure that's been done here. Now this probably you may not know, this is trabeculectomy. Trabeculectomy, this is the most commonly done glaucoma surgery. This is the most commonly done glaucoma surgery, and you know that what is trabeculectomy? It means that a portion of the trabecular meshwork is excised. So here this part of the trabecular meshwork is excised. So the aqueous humor is directly flowing into the subconjunctival space. So that's why the conjunctiva is ballooned like this. So this is called as the trabeculectomy bleb. This is called as your trabeculectomy bleb. So the portion of the trabecular meshwork is excised, the aqueous humor is directly flowing into the subconjunctival space, and the conjunctiva is ballooned like this. This is the trabeculectomy bleb. So this is trabeculectomy, which is the most commonly done glaucoma surgery. It is not prophylactic, it is curative. What is the procedure that's done here? So if you look at the procedure here, what do you see? You see this opening or hole in the peripheral iris. What is this? So hole in the peripheral iris means it is a laser peripheral iridotomy. This is a laser peripheral iridotomy. Where do you do this? This is done in angle closure glaucoma, ACG, and it is done with which laser? It is done with ND-YAG laser. So this is a ND-YAG laser peripheral iridotomy, which is done for ACG, angle closure glaucoma. Correct. So this is laser PI. Simple but commonly asked image. Next, where do we get sunflower cataract? ये बताने की ज़रूरत नहीं है, Wilson's disease. So the two ocular features of Wilson's disease, please remember, we have sunflower cataract and the other one is KF ring. So Kescher-Fleischer ring. Kescher-Fleischer ring, this is due to the deposition of copper at the level of the Descemet's membrane. So this is caused by the deposition of copper at the level of the Descemet's membrane. So these are the two ocular features of Wilson's disease, sunflower cataract and KF ring. Okay, next one. A patient presents with sudden onset pain and redness. So painful red dye. On examination, there is circumcorneal congestion, keratic precipitates on the corneal endothelium and myosed pupil. So see, three key words are there. It's a painful red eye. It's a painful red eye, and what are the important features? Keratic precipitates or KPs and myosed pupil. So keratic precipitates and myosed pupil means acute anterior uveitis. But sometimes instead of giving anterior uveitis in the option, they give iridocyclitis. So please remember, iridocyclitis is another name for anterior uveitis only. So just because they change the name, do not get confused. So anterior uveitis and iridocyclitis, they mean the same thing. Anterior uveitis and iridocyclitis, they mean the same thing. Next, let's come to this. What is the condition in the photograph associated with? Now this is a very, very important image. So if you look at the limbus, what do you see here at the limbus? These depressions that we see at the limbus, they are called as the Herbert spits. These depressions that we see at the limbus are called as the Herbert spits. And where do we get to see Herbert spits? Herbert spits are obviously seen in trachoma. So there are in trachoma, it is remembered as FISTO, F-I-S-T-O, F for follicles, I for inflammation, S for scarring. Now the features of scarring in trachoma are two. We have Arlt's line. Arlt's line is seen on the upper tarsal conjunctiva, and the other one is this, that is the Herbert spits, which are seen on the upper limbus. So these Herbert spits, these are depressions on the upper limbus. Depressions which are seen on the upper limbus. So Arlt's line and Herbert spits. So depressions seen on the upper limbus. Next one. A patient presents to the emergency with the condition shown in the photograph. Which of the following must not be done in the emergency? So see, this is a penetrating injury. This is a penetrating injury, that is injury with a sharp object. You can see an iron nail which is there. It is inside the cornea and maybe it has penetrated into the lens, into the iris, the lens and other structures also. So it's a metallic foreign body, which is a sharp metallic foreign body. So you will obviously give injection TT. You will try to do a vision assessment. You will try to do a CT scan of the orbit. Why? Because you want to see what is the extent up to which this nail has penetrated. So what you should do is these things. You have to give injection TT. You have to do a vision assessment to understand how much the eye has been damaged. You have to do a CT scan to see how much this nail has penetrated. So obviously common sense says that we should never try to remove this in the emergency, because if you remove, you end up causing more damage actually. So it has to be removed in the OT at a tertiary care hospital by a specialist ophthalmologist. So it must not be done in the emergency. MRI is contraindicated, correct. MRI is contraindicated because it is a metallic foreign body. You must not do an MRI, you have to do a CT scan, correct. Next, a patient presents with fever and a painful swelling close to the medial canthus. So what is this area? What does this area contain? So this is a painful swelling. You can see that it's an acute swelling. You can also see the pus. So ये क्या है? This is actually the area of the lacrimal sac. So it's an acute infection of the lacrimal sac, right? So it's acute dacryocystitis. So don't make a mistake with adenitis. Dacryoadenitis means it is an infection of the lacrimal gland. And lacrimal gland जो है वो यहाँ पे है ही नहीं. Lacrimal gland is located here in the supratemporal part of the orbit. This is the location of the lacrimal gland in the supratemporal part of the orbit. So if the lacrimal gland is affected, now we call it dacryoadenitis. But here this is the lacrimal sac. So this is dacryocystitis. Dacryocystitis. And why we are saying acute? Because red hai, pus hai, fever hai, painful hai. So that's why it's an acute dacryocystitis. A child is brought with high fever and swelling of the left eye. And on examination, you can see that the eyes are edematous. You are hardly able to separate the lids. You will see that the conjunctiva is ballooning out. You can see proptosis. And there is a loss of ocular movement. So common sense, this is orbital cellulitis. Orbital cellulitis, this is the most common cause of proptosis in children. So the most common cause of proptosis in a child is orbital cellulitis, and you see this, it's an acute presentation. Child is brought to us with high fever and sudden onset swelling. The lids are so tight. If you separate the lids, you see this kind of proptosis. You see a red congested eye, conjunctival edema and loss of eye movement. So this is orbital cellulitis. On the same lines, look at the next one. A patient presents with a complaint that both eyes appear large in size. So you are getting this a bilateral proptosis here and this kind of a staring look. So this kind of a staring or frightened look. So what is this? The most common cause of proptosis in adult is thyroid ophthalmopathy. What is the most common cause of proptosis in an adult? In adult, the most common cause of proptosis is thyroid ophthalmopathy, and this is one of the typical appearances of thyroid ophthalmopathy, where you get a bilateral proptosis and there is a frightened look. And this bilateral proptosis with frightened look, this has a name. It's called as Cocker's sign. So this kind of bilateral proptosis with frightened look or Cocker's sign, this is seen in thyroid ophthalmopathy, which is the most common cause of proptosis in an adult patient. Let's go to the next one. IOP evaluation is required for a patient with a dense corneal scar. So see, which is the gold standard tonometer? The gold standard tonometer is the Goldman applanation tonometer. The gold standard tonometer is the Goldman applanation tonometer. But this Goldman applanation tonometer, this has a major drawback. The major drawback is that it requires a regular corneal surface, meaning the surface of the cornea has to be smooth. So it requires a regular corneal surface. So if you have an irregular cornea, then you cannot use this instrument. So when you want to do IOP evaluation for a patient with a corneal scar, that means when there is an irregular cornea, then you have to use this instrument, which is called as your tono pen. So tono pen is the instrument which helps you to evaluate the IOP in a patient who has an irregular cornea. Okay, so these are the questions that I had in store for you today. The idea was that we should assimilate all important PYTs, and we should also go through the important points to remember, not just the questions. So I have tried. I know that you're very busy now that a date of the exam has been announced. You must have, I mean, that heartbeat has started raising. You're now counting how many days, how many hours you have. So that's why I wanted to make it as compact as possible and to revise as many questions and to recapitulate as much of important information as possible in like 2 to 3 hours. So I hope this session has been useful for all of you. So we will be uploading the PDF of the lecture in the Telegram channel very soon. So keep studying and all the very, very best for your exam. So I hope that you will be able to start your revision very, very soon. So with your revision, try to make the revision as compact and concise as possible, because the more number of times you are able to revise, the better you will be able to retain it. So do not take too much time. Go through your revised notes again, the notes that you have prepared from whatever source. Try to read the notes as many times as possible, revise the previous year's topics, and go through the PYQs, previous year's topics, and your notes. And please keep your revision as concise as possible, right? Thank you very much, everyone. All the very, very best for your exams, and happy Diwali to all of you. Chalo, bye-bye.